the conversion of light stimuli into nerve impulses. Diseases of the retina may lead to visual impairment, visual field loss, and more complex disorders such as metamorphopsia, distorted vision, and clouding. Ophthalmoscopy is the preferred diagnostic method for identifying retinal diseases, but depending on the suspected disorder, other methods such as fluorescein angiography and optical coherence tomography, OCT, may be appropriate. FO and color perception disorders. Color blindness, dyschromatopsia, I. Scent description, altered color perception. Scent etiology, congenital or acquired, example optic neuropathy due to ethambutol. Copyright congenital color perception disorders, especially red-green color vision deficiency, are very common and occur mostly in men. Affected individuals are generally unaware of their own color perception disorders. Dichromacy/2IL3. Scent description, only 2 of the 3 types of cones in the retina are fully functional. Scent types. Tutor anomaly, green color deficiency, very common, 5% of the male population. Copyright deuteranopia, green color blindness, 1% of the male population. Copyright protanomaly, red color deficiency, 1% of the male population. Copyright protanopia, red color blindness, 1% of the male population. Copyright tritanomaly, blue-yellow color weakness, very rare. Copyright tritanopia, blue-yellow color blindness, very rare. * clinical features, difficulties distinguishing colors from one another, dash. Scent diagnostics. Copyright Ishihara color test, set of color-dotted plates used to diagnose deuteranopia and protanopia. Anomaloscope, instrument used to diagnose quantitative and qualitative defects in color perception. Achromatism. Complete color blindness, very rare. WA. OLO. Degenerative diseases of the retina. Central serous retinopathy, central serous chorioretinopathy. Scent definition, serous retinal detachment at the posterior pole of the eyeball, at the macula or in the perimacular region, due to a defect in the pigment epithelium. Pathophysiology, defect in the area of Bruch's membrane/pigment epithelium. Fluid leakage from the sclera into the subretinal space. Serous retinal detachment. Etiology. Unknown. Copyright glucocorticoids and an increase in the diastolic blood pressure are possible risk factors. Copyright stress-related scent epidemiology. Mostly affects men 20 to 45 years of age. Clinical features. Hyperopia. Metamorphopsia, distorted vision. Patients perceive images as smaller than they are. Copyright relative scotoma, perception of a gray area or shadow in the central field of vision. Scent diagnostics. Copyright ophthalmoscopy, roundish detachment of the central retina. Copyright fluorescein angiography. Copyright optical coherence tomography, OCT, scent treatment. Often heals spontaneously. Copyright stress reduction. Rarely, laser coagulation, in extramacular localization, photodynamic therapy. Back collapse. Fine text outline. Macular hole. Scent definition, central small break in the macula. Scent etiology. Copyright idiopathic. Copyright secondary, example to vitreous detachment, due to trauma, following laser therapy. Scent clinical features, stage-related. Metamorphopsia. Copyright central visual field losses. Severe reduction of visual acuity. Scent treatment, vitrectomy with removal of epiretinal membranes and the internal limiting membrane of the retina. Age-related macular degeneration. See age-related macular degeneration. Retinal detachment. See retinal detachment. References. WA. CE. Dystrophic retinal diseases. Retinitis pigmentosa. Scent definition, progressive hereditary dystrophy of the retina or of the photoreceptors and the retinal pigment epithelium. Scent epidemiology, early onset, 5 to 30 years. Scent etiology. Hereditary or spontaneous mutations, 45 genes are known as triggers, example mutations in the rhodopsin gene, copyright associated with a beta-lipoproteinemia. Scent clinical features. Copyright in early stages equals normal central vision, narrowing field of vision, ring-shaped area of blindness, equals night blindness, nyctalopia. Copyright in advanced stages impaired peripheral vision, tunnel vision, equals defects in the perception of contrast and color equals glare sensitivity. Scent diagnostics. Fundoscopy equals pattern of dark spots and star-shaped blotches, deposits with bone spicule appearance, that develop from the periphery to the center of the retina. Attenuation of retinal vessels equals pale optic disc. Perimetry. Electroretinography. Scent differential diagnosis, drugs, phenothiazines, chloroquine, may induce similar symptoms to those of retinitis pigmentosa. Pseudoretinitis pigmentosa. Scent treatment, no effective treatment is known. Scent prognosis, often leads to blindness. Stargardt's disease. Scent definition, juvenile macular dystrophy, originating from the retinal pigment epithelium, autosomal recessive hereditary pattern. Scent clinical features. Back collapse. Fine text outline. Stargardt's disease. Scent definition, juvenile macular dystrophy, originating from the retinal pigment epithelium, autosomal recessive hereditary pattern. Scent clinical features. Copyright chronic progressive loss of visual acuity, onset between 10 to 30 years. Scent diagnostics. Copyright ophthalmoscopy, yellowish flecks in the area of the macula and atrophy of the pigment epithelium, Fluorescein angiography. OCT. Scent treatment/prevention. No therapy or prevention is known. Copyright poor prognosis for vision. Best disease, vitelliform macular dystrophy. Scent definition, juvenile macular dystrophy, autosomal dominant inheritance. Scent clinical features. Copyright chronic progressive visual impairment, onset typically between 4 to 10 years. Copyright people often have vision of approximate 20/40. Scent diagnostics. Copyright ophthalmoscopy, typical, yellowish, round yolk-like lesions, from Latin vitellus equals yolk, in the region of the macula. OE electroculography, EOG pathological. Copyright electroretinogram, erg normal. Scent treatment, no causal therapy is known. Scent prognosis, some patients may not have visual deterioration beyond 20/40. However, the deterioration may progress after age 40. WA. A5. Vascular diseases of the retina. Retinal hemorrhage, asterisk. Scent definition, bleeding of the vessels in the retina. Epidemiology. Thiele 7. Its peak incidence in adults, approximate 40 years of age. Peak incidence in children equals 10 to 40%, birth-related, example neonatal retinal hemorrhages, equals approximate 15%, critical disease-related, example sepsis, equals approximate 30%, abuse-related, example child abuse. Asterisk. Etiology. LLS. Degree head and neck trauma, example child abuse, head trauma, eye diseases, example age-related macular degeneration, retinal vein occlusion, retinal vasculitis, ocular ischemic syndrome, Coates disease, eye infections, example CMV retinitis, chronic disease, example diabetic retinopathy, hypertensive retinopathy, preeclampsia, hypertensive emergency coagulopathy, anemia, leukemia, example hypofibrinogenemia, sickle cell anemia, Waldenstrom macroglobulinemia, neonatal retinal hemorrhages, example instrumental labor, caesarean delivery, other, cerebral malaria, sepsis, systemic lupus erythematosus. Degree. Overview of retinal hemorrhage classification. Fundoscopic findings. Examples: flame-shaped hemorrhages, disc-shaped hemorrhages, hypertensive retinopathy, retinal vein occlusion, diabetic retinopathy, endocarditis, retinal nerve fiber layer hemorrhage, Roth spots. Intraretinal hemorrhage. Blood hemorrhages. Diabetic retinopathy. Age-related macular degeneration. Trauma. Subretinal hemorrhage. Dark red, amorphous hemorrhages. Retinal vein occlusion. Preretinal hemorrhage, boat, or D-shaped hemorrhages. Abusive head trauma. Diabetic retinopathy. Hypertensive retinopathy. Central vein occlusion. Sickle cell retinopathy. Vitreous hemorrhage. Dark, red hemorrhagic patches usually seen in the macular region. 5. Scent. Clinical features. Symptoms vary according to hemorrhage severity. Asymptomatic during early stages. Copyright blurry vision. Floaters, photopsias. Partial or complete vision loss. Back collapse. Fine text outline. Scent diagnostics. Copyright medical history, example hypertension, diabetes mellitus. Copyright visual acuity and fundoscopic exam. Copyright ocular ultrasound. Management. Copyright observation and follow-up in the following, equals solitary hemorrhages without visual impairment equals mild hemorrhage without associated chronic disease. Copyright treatment of underlying cause, example anti-VEGF injections, peripheral retinal photocoagulation, surgical intervention, Coates disease, exudative retinopathy. Scent definition. A vascular disease of the retina characterized by retinal telangiectasia, subretinal exudate, and retinal detachment. Scent epidemiology. Copyright incidence, 1:100,000. Peak incidence, 5 to 9 years of age. Predominantly affects boys. Scent clinical features. Almost always unilateral. Copyright gradual loss of vision. Copyright secondary strabismus. Leukocoria. Scent diagnostics. Copyright ophthalmoscopy. Findings include telangiectasias, aneurysms, hard exudates, and retinal detachment. Fluorescein. Angiography. Scent differential diagnosis. See differential diagnosis of leukocoria. Scent treatment. Copyright monitoring of mild cases with minimal vascular changes. Copyright sclerotherapy equals indications, moderate alterations of peripheral retinal vessels equals procedures, laser therapy or cryotherapy or retinal surgery or enucleation equals indications, severe cases with retinal detachment and / or painful blindness equals last resort equals see management of retinal detachment. Scent complications, retinal hemorrhage and / or detachment, blindness. Retinopathy of prematurity, ROP. Definition: disease of the retina with abnormal vessel proliferations that affects preterm infants. Pathophysiology: elevated and fluctuating partial pressures of oxygen. Pathological: extraretinal neovascularization, hemorrhages, formation of fibrovascular membranes, and, in severe cases, retinal detachment. Scent etiology: premature birth. Copyright ventilation or oxygen administration. Copyright birth weight equals follow-up depending upon findings or state of the ocular fundus. Examination of the ocular fundus to assess vascularization of the peripheral retina equals demarcation line between vascularized and non-vascularized retina equals extraretinal vessel formations. Formation of membranes and distortion / detachment of the retina equals plus disease, increased tortuosity, exudation, hemorrhage. Copyright follow-up screening until equals complete vascularization of the peripheral retina equals significant decrease in alterations of the peripheral retina, however, only after the expected date of delivery. Back collapse. Fine text outline. Scent treatment. Copyright in early stages of the disease, no treatment, but regular follow-up. Copyright in advanced stages, laser coagulation therapy may be indicated. Copyright in onset of retinal detachment, vitrectomy may be indicated. Scent complications: degree tractive retinal detachment. Copyright retinal holes. Blindness. Scent prevention: monitoring oxygen pressures. Regular fundoscopic exams to prevent delays in necessary treatments. And other retinal disorders. Retinal emboli / I19L. Scent definition: plaque-like lesions located in the lumen of the retinal arterioles or at bifurcations, generally consisting of cholesterol, calcification, and / or platelet fibrin. Scent epidemiology: more common in male individuals. Prevalence is approximate 0.9 to 3% in the general population. Scent risk factors: carotid artery stenosis, cardiac catheterization, diabetes mellitus, hypertension, valvular heart disease, atrial fibrillation, history of tobacco use, vascular diseases, previous surgery *. Classification, cholesterol, Holland-Horst plagues, calcific, or platelet fibrin emboli. Clinical features, mostly asymptomatic, but manifestations may include blurry vision and the partial or complete loss of vision. Associated clinical conditions: EO amaurosis fugax. Copyright central retinal artery occlusion or branch retinal artery occlusion. Diagnostics. Copyright fundoscopic exam. Cholesterol emboli, Holland-Horst plagues. Bright, yellow-colored, refractal bodies located at bifurcations of retinal vessels. Platelet fibrin emboli, long, thin, gray-colored bodies with a cast-like form located along the retinal vessels. Calcific emboli, large, white, globoid-shaped bodies located at the bifurcation of the retinal vessels. Fluorescein angiography. Copyright carotid ultrasound and echocardiography, to identify the underlying embolic source. Management, treatment of the underlying cause, which may include anticoagulation and antiplatelet therapy. Retinal periphlebitis, Eales disease, 11. Definition: a type of retinal vasculitis characterized by retinal venous inflammation, vascular occlusion, and retinal neovascularization. Etiology, idiopathic. Epidemiology. Copyright occurs predominantly in male individuals. Peak incidence, 20 years of age, 11. Pathogenesis. Copyright overlapping stages of ischemia, retinal venous inflammation, and neovascularization. Tortuous shunt vessels in the mid-peripheral retina. Retinal ischemia. Neovascularization with hemorrhaging. Clinical features: EO asymptomatic in early stages. Unilateral or bilateral decreased vision. Copyright photopsias and floaters. Copyright recurrent vitreous hemorrhages. Diagnostics. Copyright visual acuity test. Fundoscopic examination, perivascular venous sheathing, venous tortuosity, sclerosed vessels, intraretinal hemorrhage, retinal neovascularization, and vitreous hemorrhages. Fluorescein angiography, leakage surrounding the retinal veins. Differential diagnosis. Autoimmune-related causes of retinal phlebitis, example multiple sclerosis, sarcoidosis, Behçet disease, or retinal occlusive disease, example SLE, polyarteritis nodosa. Churg-Strauss syndrome, vascular diseases, example sickle cell retinopathy, branch retinal vein occlusion. Back collapse. Fine text outline. Differential diagnosis. Autoimmune-related causes of retinal phlebitis, example multiple sclerosis, sarcoidosis, Behçet disease, or retinal occlusive disease, example SLE, polyarteritis nodosa, Churg-Strauss syndrome. Copyright vascular diseases, example sickle cell retinopathy, branch retinal vein occlusion. Copyright infectious retinal vasculitis, example due to syphilis, tuberculosis, Lyme disease. Treatment. Copyright early stages, corticosteroids, local, oral, or periocular, intravitreal injection of anti-VEGF agents. Advanced stages, photocoagulation. Copyright surgical, vitrectomy may be indicated in the event of vitreous hemorrhage. Complications, vitreous hemorrhage, retinal detachment. Ocular toxoplasmosis ***. Definition: a condition of retinal and choroid inflammation caused by infection with toxoplasmosis. Clinical features: yellow-white ocular lesions, marked vitreous reaction, concomitant vasculitis, and visual field defects. For more information on ocular toxoplasmosis, see toxoplasmosis. F. VA. OS. Tumors of the retina. Retinoblastomas. Retinal pigment epithelial hyperplasia, retinal pigment epithelial hypertrophy. Copyright definition: benign hyperplasia of the retinal pigment epithelium. Copyright etiology: can be associated with familial adenomatous polyposis, FAP. Copyright diagnostics: fundoscopy demonstrates well demarcated, strongly pigmented grouped foci that may have surrounding halos of relative lucency, no prominence. Copyright treatment, not indicated. Olo. Leukocoria. Scent definition: leukocoria is an abnormal white reflection from the pupil, instead of the normal red eye reflex. Scent differential diagnosis of leukocoria: retinoblastoma, cataract, congenital or acquired. Copyright Coates disease or retinopathy of prematurity o persistent fetal vasculature o vitreous hemorrhage. Copyright ocular toxocariasis. Copyright retinal dysplasia o retinal detachment o fundus coloboma. Copyright retinal astrocytic hamartoma o retinal myelinated fibers. 1. Degree. Back collapse. Fine text outline. Euro diseases of the retina, 1/5. Copyright overlay. Acute central serous retinopathy fundus photography of a right eye. The macula appears elevated, green overlay. Otherwise, the fundus is normal. Circle, optic disc image. Source of original image, retinagallery.com. Original title, Acute Central Serous Retinopathy, Dr. Steve Cohen. Central serous chorioretinopathy, CSC, VV. Fluorescein angiography of the left eye, late phase. The macula shows marked hyperfluorescence, which extended vertically over time, resulting in the characteristic smokestack appearance. Source, CSR_ with smokestack and mushroom cloud, Quad Cities Retina Consultants, Retina Gallery licensed under public domain. Euro diseases of the retina, 3/5. Central serous chorioretinopathy in OCT v. Optical coherence tomography, OCT, of the macula. Serous detachment of the neurosensory retina can be seen. This is a characteristic OCT image of central serous chorioretinopathy. Source, Figure 1 in, Optical Coherence Tomography, an assessment of current training across all levels of seniority in 8 ophthalmic units in the United Kingdom by Wei H. Chan, John S. Schilling and Michelle Michi-Lides, BMC Ophthalmology Journal, Biomed Central, licensed under CC by 2.0. Macular hole VV. Optical coherence tomography, OCT, of the macula. There is a full-thickness macular hole with elevation of the margins. This is a typical OCT scan of a macular hole. Source, copyright IMPP. Diseases of the retina, 5/5. Full-thickness macular hole VV. Infrared reflectance, IR, left, and optical coherence tomography, OCT, right, of the right eye of a 67-year-old patient with vision loss and metamorphopsia. The central macula shows a dark discoloration. The bright paracentral spot is most likely a reflection. The green box indicates the size of the performed volume scan. The central green line indicates the level of the cross-sectional image on the right, where a full-thickness macular hole with slightly elevated margins and mild intraretinal cystoid changes can be seen. This is the typical appearance of a full-thickness macula hole on OCT. Source, copyright IMPP. Retinitis pigmentosa, early stage, 1/3. Fundus photography of a right eye. The fundus appears almost normal during the early stage of retinitis pigmentosa. Retinal vessels are mildly attenuated, the optic disc is normal, and there are no bone spicule-shaped pigment deposits. Source, Figure 1 in, Retinitis pigmentosa by Christian Hamel, Orphanet Journal of Rare Diseases, Biomed Central, licensed under CC by 2.0. Euro diseases of the retina, 2/3. Overlay. Retinitis pigmentosa, intermediate stage, 2/3. Fundus photography of a left eye. The retina shows bone spicule-shaped pigment deposits, blue overlay, in the mid-periphery of the fundus with retinal atrophy, yellow overlay, enhancing the visibility of the choroid vessels, examples indicated by arrowheads. The macula, M, shows circular depigmentation, green overlay. The retinal blood vessels are attenuated. This is the typical funduscopic appearance of retinitis pigmentosa. Circle, optic disc source, figure 2 in, retinitis pigmentosa by Christian Hamel, Orphanet Journal of Rare Diseases, Biomed Central, licensed under CC by 2.0. Euro diseases of the retina, 2/3. Copyright. Overlay. Retinitis pigmentosa, intermediate stage, 2/3. Fundus photography of a left eye. The retina shows bone spicule-shaped pigment deposits, blue overlay, in the mid-periphery of the fundus with retinal atrophy, yellow overlay, enhancing the visibility of the choroid vessels, examples indicated by arrowheads. The macula, M, shows circular depigmentation, green overlay. The retinal blood vessels are attenuated. This is the typical funduscopic appearance of retinitis pigmentosa. Circle, optic disc source, figure 2 in, retinitis pigmentosa by Christian Hamel, Orphanet Journal of Rare Diseases, Biomed Central, licensed under CC by 2.0. Copyright. Overlay. Retinitis pigmentosa, end stage, 3/3, VV. Fundus photography of a left eye. Ubiquitous confluent pigment deposits resembling bone spicules can be seen, examples indicated by white arrowheads. The optic disc, circle, appears pale, suggesting optic atrophy. Retinal vessels are attenuated. The macula is no longer preserved as the entire retina is atrophic, enhancing the visibility of choroid vessels, examples indicated by green arrowheads. These findings are typical for end-stage retinitis pigmentosa. Source, figure 3 in, retinitis pigmentosa by Christian Hamel, Orphanet Journal of Rare Diseases, Biomed Central, licensed under CC by 2.0. Overlay. Coates disease, exudative retinopathy, v. Fundus photographs, optic disc not shown. The images show telangiectasies, examples indicated by arrowheads in top and middle image, and intraretinal and subretinal exudation, indicated by green overlay in bottom image. The top image shows retinal detachment, dashed outline, indicating advanced disease. Source, copyright IMPP. Overlay. Coates disease, exudative retinopathy, v. Fundus photographs, optic disc not shown. The images show telangiectasies, examples indicated by arrowheads in top and middle image, and intraretinal and subretinal exudation, indicated by green overlay in bottom image. The top image shows retinal detachment, dashed outline, indicating advanced disease. Source, copyright IMPP. Euro diseases of the retina, 8/8. Plus disease of retinopathy of prematurity, ROP. Fundus photography of a right eye. The retina shows tortuous and dilated retinal vessels. This finding is an example of plus disease, which indicates a risk for progression to ROP. Source, figure 1, in, concurrent physiological and pathological angiogenesis in retinopathy of prematurity and emerging therapies by Chang Dai, Keith A. Webster, Amit Butt, Hong Tian, Guanfang Su, Wei Li, MDPI, licensed under CC by 4.0. Overlay. Juxtapapillary retinochoroiditis, Jensen disease, VV. Fundus photography of a right eye. There is a parapapillary zonal inflammatory lesion, green overlay, with vitreous infiltration. Fundus details are slightly blurred. M. Macula, P. Papilla, optic disc, source, copyright IMPP. Copyright overlay. Juxtapapillary retinochoroiditis, Jensen disease, VV. Fundus photography of a right eye. There is a parapapillary zonal inflammatory lesion, green overlay, with vitreous infiltration. Fundus details are slightly blurred. M. Macula, P. Papilla, optic disc, source, copyright IMPP. Macular scar in congenital toxoplasmosis. Fundus photography of the left eye of an infant, optic disc not shown. The macular area shows a sharply demarcated scar with depigmentation and hyperpigmentation, affecting both the retina and choroid. This clinical finding is a typical sign of congenital toxoplasmosis. Source, copyright IMPP. Congenital hypertrophy of the retinal pigment epithelial, CHRPE, VV. Fundus photography, optic disc not shown, multifocal, sharply demarcated, darkly pigmented lesions due to congenital hypertrophy of the retinal pigment epithelium are visible. If clustered in groups, as seen here, these lesions are sometimes called bear tracks. Source, copyright IMPP. Diseases of the retina, 2 halves. Congenital hypertrophy of the retinal pigment epithelium, CHRPE. Fundus photography. A sharply demarcated, darkly pigmented lesion is visible in the periphery of the fundus. This is the typical appearance of solitary CHRPE. Source, copyright IMPP. Leukocoria VV. Photograph of a patient with retinoblastoma. The left eye shows the normal retinal reflection, whereas the right pupil appears white, leukocoria or white pupil. This phenomenon occurs if light, example during an ophthalmologic examination or flash photography, is not reflected by the retina but by intraocular lesions such as tumors. Leukocoria is a typical early symptom of retinoblastoma. Source, retinoblastoma, NCI, artist, National Cancer Institute licensed under public domain. X. Hemolytic disease of the fetus and newborn. Hemolytic disease of the fetus and newborn, HDFN, is a condition characterized by the destruction of fetal red blood cells, RBC, and subsequent anemia. It is commonly caused by a rhesus, RH, or ABO incompatibility between the mother and fetus, although other blood incompatibilities, example KEL blood group incompatibility, and other conditions not caused by red cell alloimmunization, example congenital heart defects, can also cause HDFN. In Rh incompatibility, maternal IgG antibodies form after maternal exposure to fetal Rh-positive blood during birth or pregnancy-related complications, example feto-maternal hemorrhage. The initial pregnancy is not affected, however, subsequent pregnancies are at risk of fetal hemolysis and, in severe cases, intrauterine hydrops fetalis. ABO incompatibility, on the other hand, may lead to fetal hemolysis in the first pregnancy because of pre-existing antibodies in the mother, and it usually has a milder course of disease. Newborns may present with pallor, jaundice, and hepatosplenomegaly. Diagnosis of HDFN involves clinical and laboratory assessment for evidence of antibody-mediated hemolysis, example Coombs test. Prenatal imaging may be used to exclude hydrops fetalis. Treatment includes iron supplementation and, in the case of severe jaundice, phototherapy. In rare cases, extremely low hemoglobin, HB, levels require transfusion of red cell concentrates. Since Rh incompatibility may be fatal, anti-D immunoglobulin prophylaxis is administered to Rh-negative pregnant women. ABO incompatibility, on the other hand, rarely presents with complications and does not require immunoglobulin prophylaxis. WA 05. Definition. HDEN is a condition characterized by blood group incompatibility between the mother and fetus that leads to the destruction of fetal erythrocytes by maternal antibodies. WA CE Etiology. Scent. ABO incompatibility, present in 20% of all pregnancies, however, only 5 to 10% of newborns from these pregnancies are symptomatic. Rh incompatibility, rare following routine anti-D prophylaxis. Scent. KEL blood group system incompatibility, second most common cause of severe HDFN after Rh disease. Risk factors: maternal exposure to fetal blood during pregnancy / antenatal procedures, example amniocentesis, cesarean delivery, termination of pregnancy, copyright pregnancy-related complications, example ectopic pregnancy, placental abruption, OE trauma. References to ILS. WA. CE. Pathophysiology. ABO incompatibility. Highest risk: mother with blood group O, newborn with blood group A or B. Maternal antibodies, anti-AN/or anti-B, against non-self antigens of the ABO system are present even if sensitization has not occurred, so fetal hemolysis may occur during the first pregnancy. Rh incompatibility. In an Rh negative mother and Rh positive newborn, maternal exposure to fetal blood, feto-maternal hemorrhage, production of maternal IgM antibodies against the Rh antigen equals over time, seroconversion to Rh-IgG, able to cross the placenta, in a subsequent pregnancy with an Rh positive newborn, rapid production of maternal IgG anti-D antibodies to fetal Rhd antigens Rh-LGG agglutination of fetal RBCs with hemolytic anemia risk of HDFN with possible hydrops fetalis. Kel blood group system incompatibility 41.5. Plus the Kel blood group system includes K, K1, K, K2, KP, KP registered, JS registered, and JS registered antigens. For more information, see Kel antigen system, which can trigger substantial immune responses. Responsible for up to 10% of severe cases of HDFN. 6. Maternal exposure to Kel antigen in previous pregnancy through the placenta or through blood transfusion. Sensitization and production of maternal anti-Kel antibodies. Antibodies enter circulation of Kel-positive fetus through placenta. Destruction of fetal RBC precursors and mature RBCs. J. Production of RBCs and T. Hemolysis. Severe fetal anemia. Back collapse. Fine text outline. Subtypes and variants. Non-immune hydrops fetalis, 71. Definition: a subgroup of hemolytic diseases of the fetus and newborn not caused by red cell alloimmunization. Epidemiology. Copyright incidence: 1 in 4,000 pregnancies. Copyright accounts for over 90% of all hydrops fetalis cases. Etiology. Copyright congenital heart defects and arrhythmias. Copyright chromosomal aberrations, example Turner syndrome, Down syndrome, trisomy 18, copyright severe fetal anemia, example thalassemia, twin-to-twin transfusion syndrome, feto-maternal hemorrhage, copyright congenital torch infections. Especially parvovirus B19 infection, pathophysiology, severe fetal anemia, hypoxia, hepatic and renal blood flow, activation of RAAS7, central venous pressure and J lymphatic flow, fetal edema. 8. WA. OSET. Clinical features. Prenatal. Hydrops fetalis, expected in cases of Rh incompatibility and in non-immune hydrops fetalis. Postnatal. Neonatal anemia 1. Hepatosplenomegaly. Neonatal jaundice O, usually present at birth or manifests within the first 24 hours of life. Copyright in Rh incompatibility, unconjugated bilirubin levels may be dangerously high, causing kernicterus. Plus hypoxia, prematurity. Scattered petechiae, rare but associated with poor prognosis. 9. QB-ABO incompatibility usually has a significantly milder course of disease than Rh incompatibility. Copyright anemia may conceal cyanosis. WA. CE. Diagnostics. The diagnosis of HDFN requires evidence of hemolysis in the presence of feto-maternal blood incompatibility. Prenatal diagnosis. Imaging. Copyright ultrasound, to determine hydrops fetalis fetal plural or pericardial effusions equals fetal ascites equals fetal subcutaneous or nuchal edema equals placental edema. Copyright Doppler sonography of fetal blood vessels, increased flow rate indicates fetal anemia. Postnatal diagnosis. If the newborn has signs of hemolysis, conduct a Coombs test, either direct or indirect. Copyright Rh incompatibility, positive. Copyright ABO incompatibility, weak positive or negative. Back collapse. Find text. Outline. X. Hemolytic disease of the fetus and newborn. Differential diagnoses. ABO versus Rh incompatibility. ABO incompatibility. Rh incompatibility incidence * common rare. Disease during the first pregnancy * common rare. Clinical symptoms * generally normal to mild, may be asymptomatic * mild to severe. Coombs test, direct or indirect, sent weak positive or negative * positive spherocytosis present rare. Differential diagnoses of petechiae in newborns. Neonatal alloimmune thrombocytopenia. Sent description, a rare condition in newborns characterized by maternal fetal platelet incompatibility resulting in fetal thrombocytopenia. Sent epidemiology, the leading cause of severe thrombocytopenia in the newborn. Sent pathophysiology, formation of maternal antibodies against fetal platelets, most commonly targeting platelet antigen 1A, maternal IgG cross the placenta and result in the destruction of fetal platelets. Fetal and neonatal thrombocytopenia. Sent clinical features O mild. Asymptomatic thrombocytopenia O moderate, petechia and / or ecchymosis within a few hours after birth O severe, spontaneous intracranial hemorrhage. Other. Sent immune thrombocytopenic purpura. Sent Kazabok-Merit syndrome. Sent perinatal infections. Sent for an overview of thrombocytopenias and disorders of platelet function, see differential diagnosis of platelet disorders. The differential diagnoses listed here are not exhaustive. A7 OES. Treatment. Sent prenatal. Copyright intrauterine blood transfusion via the umbilical vein, umbilical artery, peritoneal cavity, or heart, should only be performed in centers with experience in fetal transfusions. Copyright possible LV immunoglobulin, IVIG, in severe cases. Sent postnatal. Copyright anemia, iron supplementation and, if necessary, RBC transfusion. 4O hyperbilirubinemia, phototherapy, if necessary, exchange transfusion with red blood cells. OC treatment in neonatal jaundice. Copyright in severe cases, 4 immunoglobulin, IVIG, may be administered. References, 4. GRYFAs. Prevention. Screening. Sent ABO and Rh typing of the mother. ORH positive mothers do not need further screening. ORH negative mothers, screening for anti-D antibodies equals no anti-D antibodies. Unsensitized mothers antibody screening repeated at 28 weeks gestation and at delivery. See anti-D immunoglobulin, RO-GAM, below. Equals anti-D antibodies manifest with an anti-D antibody titer 1:8, which indicates maternal sensitization to fetal Rh antigens, sensitized mothers. Further monitoring with amniocentesis and imaging is required for evidence of hemolysis. Back collapse. Find text outline. Hemolytic disease of the fetus and newborn. Treatment. Sent prenatal intrauterine blood transfusion via the umbilical vein, umbilical artery, peritoneal cavity, or heart, should only be performed in centers with experience in fetal transfusions. Copyright possible LV immunoglobulin, IVIG, in severe cases. Sent postnatal anemia, iron supplementation and, if necessary, RBC transfusion. TAO hyperbilirubinemia, phototherapy, if necessary, exchange transfusion with red blood cells. OC treatment in neonatal jaundice. O in severe cases, 4 immunoglobulin, IVIG, may be administered. References, 14. O. CE. Prevention. Screening. Scent ABO and RH typing of the mother. Copyright RH positive mothers do not need further screening. ORH negative mothers, screening for anti-D antibodies equals no anti-D antibodies. Unsensitized mothers antibody screening repeated at 28 weeks gestation and at delivery. See anti-D immunoglobulin, RO-GAM, below. Anti-D antibodies manifest with an anti-D antibody titer 1:8, which indicates maternal sensitization to fetal Rh antigens, sensitized mothers. _. Further monitoring with amniocentesis and imaging is required for evidence of hemolysis. Fetal-maternal hemorrhage in Rh negative mother 1. Conduct a Rosette test, initial test of choice. This is a qualitative test that assesses whether fetal-maternal hemorrhage has occurred. The APT test is an alternative to the Rosette test, but it only differentiates whether the origin of blood is fetal/newborn or from the mother, example from newborn gastrointestinal, stool, vomiting, or pulmonary bleeding. Antepartum hemorrhage, example vasa previa. 2. If the Rosette test is positive, conduct a Kleho or Betka test. Quantitative testing to evaluate fetal-maternal hemorrhage equals the amount of fetal hemoglobin determines the amount of anti-D immunoglobulin necessary. Flow cytometry is an alternative, but its use is limited by equipment and costs. Plus fetal Rh genotyping. Anti-D immunoglobulin, RO-GAM. Scent background. Copyright pathophysiology, see rhesus incompatibility above. Copyright anti-D prophylaxis protects newborns in subsequent pregnancies. 1. Copyright only indicated in unsensitized mothers. Scent indication and implementation. OE anti-D prophylaxis should be administered during the 28th week of gestation, and within 72 hours following the birth of an Rh-positive baby. Copyright the efficacy of anti-D prophylaxis relies on antibody-mediated immunosuppression. Scent further indications in Rh negativity. Copyright following a miscarriage, ectopic pregnancy, or termination of pregnancy bleeding during pregnancy. Copyright following invasive procedures, example amniocentesis, chorionic villus sampling, dosage. Copyright standard dose, 300 mg, 1500 IU, 4/IM. Copyright if whole fetal blood is 30 ml, i.e., fetal RBCs 15 ml 300 mg, 1500 IU, IM should be given for every 30 ml of fetal blood volume. 2 HL11 Copyright adjusted dose in the first trimester, 50 to 120 mg 1/1. References 21L12. Back collapse. Fine text outline. Urohemolytic disease of the fetus and newborn, 1/1. First pregnancy. YY mother Rh. Maternal exposure EA to fetal Rh plus RBCs AZ, mostly during delivery. Father NSZ Rh plus, I4. Rhesus, Rh, incompatibility in pregnancy. Copyright emboss. Between pregnancies. ZN. Y. / equals _ anti-Rh antibodies low _ RHD alloimmunization, AEX / plus S / I. Subsequent pregnancies. 7. Agglutination of fetal RBCs and anti-Rh antibodies. Hemolysis hot. Of fetal complications. Prenatal, hydrops fetalis. Scent perinatal mortality. Scent postnatal, anemia, jaundice, hepatosplenomegaly. Hemolytic disease of the fetus and newborn, 1/1. Overlay. Hydrops fetalis VV. Ultrasound, axial plane, of a fetus at 30 weeks gestation with congenital Zika virus infection. Examination of the fetal head, A, shows microcephaly and hydranencephaly, absent cerebral hemispheres replaced by anechoic CSF. At the level of the posterior fossa, B, the cerebellar vermis is not visible, green arrowhead, and nuchal edema, red arrowhead, is seen. The heart, C, is surrounded by bilateral pleural effusions, yellow arrowheads. Anechoic ascites, blue arrowhead, is seen in the abdomen, D. Subcutaneous edema is present, white arrowheads on C and D. The findings are consistent with hydrops fetalis, the abnormal accumulation of fluid in at least 2 extravascular compartments, including body cavities and soft tissues. Hydrops fetalis is associated with a broad spectrum of immune and non-immune disorders, example hematologic and metabolic disorders, tumors, intrauterine infections, malformations. H, heart, L, liver. Source, Fig 1, in Zika virus infection and stillbirths, a case of hydrops fetalis, hydranencephaly and fetal demise by Sarno M., Sacramento, GA. X. Neonatal jaundice. Neonatal jaundice is one of the most common conditions occurring in newborn infants and is characterized by elevated levels of bilirubin in the blood, total serum bilirubin concentration 5 mg/dl or 85.5 mol/L. The most common cause of neonatal jaundice is a physiological rise in unconjugated bilirubin, which results from hemolysis of fetal hemoglobin and an immature hepatic metabolism of bilirubin. Physiological neonatal jaundice is harmless and occurs in most infants between the 2nd and the 8th day of life. Pathologic neonatal jaundice can be conjugated or unconjugated and is typically a symptom of an underlying disease. Possible conditions include hemolytic anemias, blood group incompatibilities, Gilbert syndrome and Crigler-Najjar syndrome, G6PD deficiency, and congenital biliary flow obstructions. Hyperbilirubinemia can cause drowsiness and poor feeding in the newborn, and in severe cases, unconjugated bilirubin can cross the blood-brain barrier and cause permanent neurological damage, kernicterus. The degree of hyperbilirubinemia can be measured by transcutaneous and/or serum bilirubin measurements. Treatment modalities include phototherapy, intravenous immune globulin, IVIG, and exchange transfusion, in addition to specific therapies for the respective underlying conditions. Treatment is targeted at reducing the risk of kernicterus and hence permanent neurological sequelae. Go. OES. Classification. Types of neonatal jaundice features PHYIGIP. Type of hyperbilirubinemia * always D. Hyperbilirubi can be either conjugated or unconjugated hyperbilirubinemia. Onset * 24 hours after birth can present. Peak total serum bilirubin * 15 mg/dl co. Daily rise in bilirubin levels equals * 5 mg/dl/day. Etiology sent hemolysis of fetal hemoglobin and an immature hepatic metabolism of bilirubin sent. See etiology below. 7 *. So. Etiology. Overview of I, of LJ-LLL2 type of hyperbilirubinemia mechanism. Etiology. Plus hemolytic disease of the newborn, example ABO incompatibility, RH incompatibility, * erythrocyte enzyme defects, example G6PD deficiency, pyruvate kinase deficiency, erythrocyte membrane defects, example hereditary spherocytosis * hemolytic scent. Production of bilirubin VT, e.g. EEM, hemoglobinopathies, example sickle cell anemia, thalassemias, hematomas, example vacuum-assisted delivery, vitamin K deficiency bleeding, infection/sepsis, see neonatal infection, polycythemia pathological unconjugated hyperbilirubinemia Gilbert syndrome Crigler-Najjar syndrome deficiency of UDP glucuronidyltransferase hypothyroidism. Conjugation of bilirubin. GI obstruction, example pyloric stenosis, bowel obstruction, Hirschsprung disease, cystic fibrosis, breast milk jaundice, breastfeeding jaundice, malnutrition. Non-hemolytic. Decreased stool passage. T. Enterohepatic circulation of bilirubin. J. Hepatic uptake of bilirubin. Rotor syndrome. 3. Alagille syndrome. 4. Torch infections. Dubin-Johnson syndrome. Sepsis. Idiopathic neonatal hepatitis alpha 1 antitrypsin deficiency. Scent. Intrahepatic. Pathological conjugated hyperbilirubinemia, cystic fibrosis. J. Galactosemia, hypothyroidism. Medication. Scent. Excretion of bilirubin. Biliary atresia, biliary/colitical cyst tumors/strictures. Back collapse. Fine text outline. Extrahepatic. Biliary atresia, biliary/colitical cyst tumors/strictures. Scent. Extrahepatic. Scent. Both conjugated and unconjugated hyperbilirubinemia. Scent. Hepatitis mixed hyperbilirubinemia * combined, occur. Scent. Cirrhosis. FOKO, EXO. Pathophysiology. Physiological neonatal jaundice. 5. Unconjugated hyperbilirubinemia caused by copyright short lifespan of erythrocytes in the newborn, copyright insufficient hepatic bilirubin metabolism, due to immature UDP glucuronolacyltransferase. Enterohepatic circulation of bilirubin. 1. Pathological neonatal jaundice. 5. Scent. Hyperbilirubinemia can be caused by multiple mechanisms. Copyright increased production of bilirubin, example conditions with increased hemolysis, decreased hepatic uptake, example due to liver immaturity, copyright decreased conjugation, example Crigler-Najjar syndrome, copyright impaired excretion, example conditions with cholestasis, gastrourinary malformations, copyright increased enterohepatic circulation, example conditions with decreased intestinal motility, breastfeeding jaundice. OAE. Subtypes and variants. Breastfeeding jaundice. 5. Scent definition, a type of neonatal jaundice caused by insufficient breastfeeding. Scent pathophysiology, insufficient breast milk intake equals lack of calories and inadequate quantities of bowel movements to remove bilirubin from the body. T. Enterohepatic circulation, increased reabsorption of bilirubin from the intestines. Unconjugated hyperbilirubinemia. Scent clinical features, onset within 1 week. Scent treatment, increase breastfeeding sessions, rehydration. Breast milk jaundice. 5. Scent definition, a type of neonatal jaundice caused by increased levels of B-glucuronidase in maternal breast milk. Pathophysiology, increased concentration of B-glucuronidase in breast milk. T. Deconjugation and reabsorption of bilirubin. Persistence of physiologic jaundice with unconjugated hyperbilirubinemia. Copyright B-glucuronidase is found in breast milk and the intestinal brush border. Copyright deconjugation of bilirubin by bacterial B-glucuronidase can lead to pigment stone formation. 6. Scent clinical features, onset within 2 weeks after birth, lasts for 4 to 13 weeks. Scent treatment. Copyright continued breastfeeding and supplementation with formula feeds, phototherapy, if required. WA. CE. Clinical features. Scent physiological neonatal jaundice asymptomatic, except for transient icterus. Copyright jaundice manifests after 1 degree day of life and usually resolves without treatment in 1 week, in term infants, or 2 weeks, in preterm infants. Usually most severe on the 5th day. Scent pathological neonatal jaundice, jaundice can appear 1 week in term infants and 2 weeks in preterm infants. Copyright clinical features of the underlying cause. Back collapse. Fine text. Outline. Diagnostics. Scent physical examination for icterus. The American Academy of Pediatrics, AAP, recommends regular assessment of all neonates for jaundice, every 8 to 12 hours, while in the hospital. Asterisk bilirubin tests, 27IL6. Degree. Degree. Transcutaneous bilirubin measurement, TCB, A. Asterisk bilirubin levels 95 percentile on nomogram indicate neonates at high risk for developing neurological sequelae. Serum bilirubin measurement total serum bilirubin measured equals differentiation of direct, conjugated, and indirect, unconjugated, bilirubin for assessment of degree of jaundice based on nomogram. Infants 95 percentile must be evaluated for pathological jaundice, see other laboratory tests below. Plus other laboratory tests. Degree. Complete blood count, including reticulocyte count, blood group direct and indirect Coombs test, CRH incompatibility. Markers of inflammation liver enzymes total serum protein and serum albumin TSH and free T, G6PD activity, in patients with G6PD deficiency. Physiological neonatal jaundice is a diagnosis of exclusion. Laboratory tests should first rule out all pathological causes of neonatal jaundice. Jaundice in a term newborn less than 24 hours old is always pathologic. Treatment. Phototherapy /1I9271. Phototherapy is the primary treatment in neonates with unconjugated hyperbilirubinemia. Scent indications. Degree. Degree. For infants born equals 35 weeks gestation, threshold bilirubin levels, TSB, for treatment are based on the American Academy of Pediatrics, AAP, phototherapy nomogram, which divides the infants into 3 risk groups, A7 low-risk infants, equals 38 weeks and well medium risk infants, 38 weeks with risk factors, example isoimmune hemolytic disease, G6PD deficiency, sepsis, or 35 to 37 weeks and well high-risk infants, 35 to 37 weeks with risk factors. For infants born. Degree. Exposure to blue light, non-UV, wavelength, 420 to 480 nanometers, photoisomerization, major mechanism, and photooxidation, minor mechanism, of unconjugated, hydrophobic, bilirubin in skin to water-soluble forms. Excretion of water-soluble form in urine and or bile continued until total bilirubin levels occurs in infants with elevated direct bilirubin, conjugated bilirubin 2 mg/dl, following phototherapy thought to be caused by abnormal accumulation of bronze-colored pigments, photoisomers of bilirubin, within the skin presents with a reversible grayish-brown discoloration of the skin, urine, and serum usually resolve slowly after cessation of phototherapy without complications. Back collapse. Fine text outline. Newborns with TSB levels below the phototherapy threshold usually do not require treatment. 11. Exchange transfusion. Most rapid method for lowering serum bilirubin concentration. Scent indications. O threshold in a 24-hour-old term baby is a total serum bilirubin value 20 mg/dl. Copyright inadequate response to phototherapy, or a rapid rise in the total serum bilirubin level, 1 mg/dl/hour in less than 6 hours. Copyright acute bilirubin encephalopathy eohemolytic disease, severe anemia. Scent procedure. O use ABO matched and Rh negative erythrocyte concentrate. Copyright exchange blood in quantities of 5 to 20 ml via an umbilical venous catheter until total serum bilirubin is. Scent indications, used in cases with immunologically mediated conditions, or in the presence of Rh, ABO, or other blood group incompatibilities that cause significant neonatal jaundice. Scent dose range for IVIG, 500-1000 mg/kg. WA. FO, IEEE. Complications. Acute bilirubin encephalopathy. Scent onset within first days of life. Scent lethargy, infantile hypotonia, poor feeding. Scent fever, shrill cry. Scent stupor, apnea, seizures sent possibly fatal if neurotoxicity is severe. Kernicterus, chronic bilirubin encephalopathy. Develops over first years of life. Pathophysiology, deposition of unconjugated bilirubin, liposoluble, in the basal ganglia and / or brain stem nuclei. Sent clinical features. Copyright cerebral paresis, hearing impairment, vertical gaze palsy. Movement disorder, chorioathetosis, apparent intellectual and developmental disabilities. Dental enamel hypoplasia. EREBYIMI. We list the most important complications. The selection is not exhaustive. 7 CES. Prognosis. Favorable in most cases. Sent in rare cases, kernicterus may occur, resulting in permanent neurological sequelae. Back collapse. Fine text outline. X. Neonatal jaundice. Sent procedure. Use ABO matched and Rh negative erythrocyte concentrate. Degree exchange blood in quantities of 5 to 20 ml via an umbilical venous catheter until total serum bilirubin is. Sent indications, used in cases with immunologically mediated conditions, or in the presence of Rh, ABO, or other blood group incompatibilities that cause significant neonatal jaundice. Sent dose range for IVIG, 500-1000 mg/kg. Odor. AST. Complications. Acute bilirubin encephalopathy. Sent onset within first days of life. Sent lethargy, infantile hypotonia, poor feeding. Sent fever, shrill cry. Sent stupor, apnea, seizures. Sent possibly fatal if neurotoxicity is severe. Kernicterus, chronic bilirubin encephalopathy. Sent develops over first years of life. Pathophysiology, deposition of unconjugated bilirubin, liposoluble, in the basal ganglia and / or brain stem nuclei. Sent clinical features. Cerebral paresis, hearing impairment, vertical gaze palsy. Movement disorder, chorioathetosis, apparent intellectual and developmental disabilities. Dental enamel hypoplasia. We list the most important complications. The selection is not exhaustive. OA. Low. Prognosis. E. Favorable in most cases. E. In rare cases, kernicterus may occur, resulting in permanent neurological sequelae. OOES. Prevention. Interruption of enterohepatic circulation with adequate enteral nutrition. 7 plus frequent feeds with breast milk. 1. Plus protein-rich nutrition in the form of breast milk or special formula feeds. In the case of dehydration, protein-rich feeding solutions are preferred over glucose or water. Back collapse. Fine text outline. Neonatal jaundice VV. Source, Jaundice in Newborn, Dr. Hudson, Wikimedia Commons licensed under public domain. 95 percentile, dash dash 4 dash 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 4 dash 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 LNS, ahead LH of ELLNEELHEEL 2075 percentile 342. LH 40 percentile high risk zone. CRH high intermediate risk zone equals EEEEE Navy Air Pays Bri IEEAE Srocknas equals IJ, AE. Yo I pound, dash slash EECLIECEEV 9, RA. X 53850. 000 12 24 36 48 60 72 84 96 108 120 132 144. Postnatal age hours. Butani nomogram VV. The Butani nomogram defines age-specific percentile curves to evaluate the risk of developing pathological neonatal jaundice. Depending on the measured serum bilirubin value, several risk zones are defined. Neonates in the high-risk zone must be evaluated for pathological jaundice. Copyright Emboss. Neonatal jaundice, 2 halves. Neonatal phototherapy VV. Neonate under a phototherapy lamp except for the diaper and socks, the neonate is undressed to expose the greatest skin surface area. The phototherapy goggles protect from potential retinal damage. Source: Billy Light with Newborn, Jeremy Kemp, Wikimedia Commons licensed under public domain. Kernicterus VV. Coronal brain section, kernicterus, yellow, in the basal ganglia and the hippocampus on both sides. Source: Copyright IMPP. X. Inherited hyperbilirubinemia. Hyperbilirubinemia is characterized by serum bilirubin levels of equals 1.1 mg/dl. In contrast to acute or chronic cholestatic liver disorders, which may also lead to increased serum bilirubin levels, syndromes associated with hyperbilirubinemia lead to isolated hyperbilirubinemia and hence do not affect liver enzymes. These syndromes cause a rise in either unconjugated or conjugated bilirubin. The clinical manifestation of hyperbilirubinemia is relatively mild. Transient jaundice is the primary symptom. With the exception of Crigler-Najjar syndrome type, inherited hyperbilirubinemia syndromes do not require medical management. Patients with hyperbilirubinemia generally have a good prognosis. Classification. Isolated hyperbilirubinemia types. Etiology: example, excess release *, hemolytic anemia. T. Indirect bilirubin, unconjugated bilirubin, * Gilbert syndrome, * defective conjugation, * Crigler-Najjar syndrome, __, * Dubin-Johnson syndrome, CASU, * defective excretion, conjugated bilirubin, Rotor syndrome. B. Individuals with Crigler-Najjar or Gilbert syndrome cannot conjugate bilirubin. And individuals with Rotor syndrome or Dubin-Johnson syndrome cannot get rid of direct bilirubin. WA. OE. Gilbert syndrome. Scent epidemiology. Copyright. Most common inherited hyperbilirubinemia, the prevalence is 3 to 7% in the U.S. JOT? Age of onset, adolescence, 2. Plus etiology/IL4-IOE mutation in the promoter region of UGT1A1 gene, mild reduction of UDP-glucuronocyltransferase activity, conjugation of bilirubin F, indirect bilirubin. O alternative, missense mutation in UGT1A1 gene FA. Copyright impaired hepatic bilirubin uptake. Scent inheritance, autosomal recessive or autosomal dominant. Scent clinical features: asymptomatic or unspecific symptoms such as fatigue and loss of appetite. Copyright transient, usually mild jaundice, varying from mild scleral jaundice to general jaundice. 5. Scent triggering factors of transient jaundice. Copyright stress, example trauma, illness, exhaustion, fasting periods. Copyright alcohol consumption. Scent diagnosis. Copyright slightly F, indirect bilirubin but back collapse. Fine text outline. X. Inherited hyperbilirubinemia. Scent diagnosis. Copyright slightly T, indirect bilirubin but VM. Yes. Crigler-Najjar syndrome. Crigler-Najjar syndrome type. Scent etiology, UDP-glucuronocyltransferases, almost completely absent. Scent inheritance, autosomal recessive. Scent clinical features: excessive, persistent neonatal jaundice. Copyright Kernicterus. Neurological symptoms, onset during infancy or later in childhood. Scent diagnosis. Copyright F, indirect bilirubin, 20 to 50 mg/dl. Normal liver function tests. Copyright no evidence of hemolysis. Scent treatment: phototherapy, conversion of unconjugated bilirubin, hydrophobic bilirubin, to more polar, water-soluble form. 7. Excretion via duct, urine and/or bile, plasmapheresis during acute rises in serum bilirubin levels. Copyright tin protoporphyrin. Copyright calcium carbonate. Liver transplantation is the only curative treatment. Scent prognosis: without treatment, Crigler-Najjar syndrome type is incompatible with life because it causes kernicterus. If treated, patients may survive past puberty, but most will eventually develop kernicterus. Crigler-Najjar syndrome type 2, ARIA syndrome. Etiology, reduced levels of UDP-glucuronidyltransferase scent inheritance, autosomal recessive or autosomal dominant scent clinical features O often asymptomatic O no neonatal jaundice, although jaundice may occur during the patient's first year of life, OE no neurological symptoms scent diagnosis degree 7 indirect bilirubin, serum bilirubin levels, scent treatment, patients are less likely to develop kernicterus. Specific treatment may therefore not be required. The following treatment options are, however, available if patients become icteric. Phenobarbital leads to induction of UDP-glucuronidyltransferase. Copyright phototherapy, as in type E. Avoid hormonal contraception and hepatic enzyme inhibitors scent prognosis O usually favorable O management of jaundice allows for normal quality of life. A5. Dubin-Johnson syndrome. Plus etiology, defective multi-drug resistance associated protein 2, MRP2, impaired excretion of conjugated bilirubin from the hepatocytes into the bile canaliculi scent inheritance, autosomal recessive scent clinical features O mild to moderate jaundice equals onset often occurs during adolescence equals may worsen because of medication, particularly contraceptives, or pregnancy. Back collapse fine text outline. X inherited hyperbilirubinemia. Scent diagnosis copyright 7 indirect bilirubin, serum bilirubin levels 1 scent treatment, patients are less likely to develop kernicterus. Specific treatment may therefore not be required. The following treatment options are, however, available if patients become icteric. Copyright phenobarbital leads to induction of UDP-glucuronidyltransferase. Copyright phototherapy, as in type E. Avoid hormonal contraception and hepatic enzyme inhibitors scent prognosis copyright usually favorable O management of jaundice allows for normal quality of life. CES. Dubin-Johnson syndrome. Plus etiology, defective multi-drug resistance associated protein 2, MRP2, impaired excretion of conjugated bilirubin from the hepatocytes into the bile canaliculi scent inheritance, autosomal recessive scent clinical features E mild to moderate jaundice equals onset often occurs during adolescence may worsen because of medication, particularly contraceptives, or pregnancy copyright splenomegaly may occur in rare cases. Scent diagnosis copyright direct hyperbilirubinemia, direct bilirubin/total bilirubin up to 50%. Liver biopsy, dark, granular pigmentation, due to accumulation of epinephrine metabolites, scent treatment, not required, benign condition, scent special considerations be careful when administering a drug that is toxic to the liver, as it may worsen jaundice. Copyright contraindication for oral contraception And in Dubin-Johnson syndrome, the liver appears dark. CE. Rotor syndrome. Etiology, defective organic anion transport proteins, OATP, 1B1 and 1B3 in hepatocytes, impaired transport and reduced storage capacity of conjugated bilirubin, direct bilirubin, 1, 7 scent inheritance, autosomal recessive scent clinical features, usually asymptomatic but mild jaundice may occur, milder presentation compared to Dubin-Johnson syndrome, scent diagnosis copyright moderate, direct hyperbilirubinemia and mild, indirect hyperbilirubinemia copyright normal liver function test copyright. Urinary coproporphyrins and 3, fraction of isomer. B. In Rotor syndrome, the liver appears regular, no dark pigmentation. Back collapse fine text outline. Inherited hyperbilirubinemia, 1/2. Unconjugated conjugated bilirubin. Macro_SOM. Co-at uptake heme conjugation X1 drainage S0 / Bilinogen I. Copyright, Sterco Bilinogen. Copyright at unconjugated bilirubin at urobilinogen at a bil erkabilin. CP conjugated bilirubin, albumin. Bilirubin metabolism VV. 1. Hemoglobin is broken down into heme and globin in the spleen and, to a lesser extent, in the bone marrow. 2. Macrophages break heme down into unconjugated bilirubin. Bound to albumin, unconjugated bilirubin is transported in the bloodstream and taken up by the liver. 3. Bilirubin is conjugated in the liver and secreted in bile. 4. In order to be secreted, conjugated bilirubin enters the blood to reach the hepatocytes with a direct connection to the bile canaliculi. At this stage, conjugated bilirubin is detectable in the blood. 5. Bilirubin reaches the intestine via the bile. Intestinal bacteria convert bilirubin to urobilinogen. 6. Most of the urobilinogen is converted into stercobilinogen and then stercobilin. Stercobilin is excreted via the stool, giving it its characteristic brown color. 7. A smaller portion of urobilinogen is reabsorbed and follows two different paths. 8. Most of it undergoes hepatobiliary recirculation, while the rest is filtrated in the kidney. Or, 9. The remainder gets filtrated in the kidneys. In the urine, urobilinogen is oxidized to urobilin, which is responsible for the characteristic yellow color. Parasinusoidal I equals space. Underscore. SSIE equals me 7. Smiley face, 2. Hepatocyte A, 1 say transporter ANS EEAOE Dubin Johnson. AO. ECO, syndrome UIGGCE, me 4. Equals UDP equals. Glucuronidyltransferase Gilbert syndrome. Discontinuous A, endothelium at. Sinusoid N equals. 3JST endoplasmatic equals 2ETI1 reticulum D equals IC. Bile canalicularis. IIIE equals LSS Krigler-Najjar equals Lee-Sent/syndrome S Euro equals C pi equals S equals plus equals conjugated PSA at 4 go, ES equals, smiley face, EE backslash equals Iliabin S2 equals bilirubin equals asterisk, equals, 1, equals, Y. Equals B, C equals 5Z2 equals R backslash SMSS and backslash equals a get EE, Ren SOO, Rotor syndrome IEEE do at PAB 1/1B4 equals. Hereditary hyperbilirubinemia. Defects in the bilirubin conjugation and excretion pathways within hepatocytes result in hyperbilirubinemia. Red indicators link. Hereditary hyperbilirubinemia with corresponding dysfunctional enzymes and transporters. Copyright Boss. Euro-inherited hyperbilirubinemia, 1/1. Dubin-Johnson syndrome VV. Partial hepatectomy specimen due to a deficiency of biliary transport proteins, the liver tissue appears darkly pigmented. This finding is typical for Dubin-Johnson syndrome. Furthermore, a large gray to yellowish lesion, white arrow, is seen next to the right hepatic vein. Histological examination revealed intrahepatic cholangiocarcinoma. Source, Figure 2A and B, in, Hepatectomy for cholangiocarcinoma in one patient with Dubin-Johnson syndrome by Chris Gamboa C., Yanez R., Martinez J.A., ETAL, Revista Chilna de Sirigaya, licensed under CC by 4.0. Modifications, image cropped. X cerebral palsy. Cerebral palsy, CP, is a heterogeneous group of disorders affecting the muscle tone and the development of movement and posture. CP results from a non-progressive damage to the brain in utero or during infantile development up to the age of 3 years. Depending on the affected brain area, spastic, ataxic, or dyskinetic cerebral palsy develops. While, in many cases, there is no identifiable cause, risk factors for cerebral palsy are prematurity, perinatal complications such as chorioamnionitis, birth trauma with intracerebral hemorrhage, or postnatal infections such as meningitis. The diagnosis of CP is usually not made until features become apparent as children fail to meet certain milestones during the post-neonatal period, example inability to roll over or sit independently. Physical indicators of spastic cerebral palsy include spastic paresis of multiple limbs and joint contractures, scissors gait, and persistence of primitive reflexes. Patients with non-spastic cerebral palsy present with dysarthria and abnormal involuntary movements, chorioathetoid, dystonic, or ataxic, that worsen with stress. Seizure disorders and intellectual disability are associated with all types. Diagnosis is mainly based on the clinical picture, but cranial ultrasound or MRI can help identify the causative lesion, example hemorrhage, brain malformation. Since there is no cure, management follows a multidisciplinary approach with a focus on treating contractures, example bracing, antispasmodics, physical therapy, surgery, and ensuring social participation, example speech therapy, social support. Depending on the severity and type of cerebral palsy, patients may be slightly restricted or severely disabled and unable to walk. Yes. Epidemiology. Most common motor disability in children approximate 2/1000 live births. 1. References to epidemiological data refers to the U.S., unless otherwise specified. L. CES. Etiology. Plus idiopathic, most cases, * risk factors. Degree preterm birth and low birth weight, most important risk factors, torch infection, perinatal asphyxia, intracranial hemorrhage, periventricular locomalacia, structural abnormality of the brain, neonatal seizures, kernicterus, postnatal infection, example meningitis, encephalitis, thyroid disorder in pregnancy. Degree. Studies have shown that antenatal administration of magnesium sulfate in birthing parents at risk of premature delivery, example likely to enter preterm labor within 24 hours, has neuroprotective effects on the fetus and is associated with reduced incidence of cerebral palsy. SIM4LL5. References. WA. CE. Classification. Spastic cerebral palsy, spastic paresis of one or more limbs, 75% of cases, non-spastic cerebral palsy, copyright dyskinetic, abnormal involuntary movements, chorioathetoid, dystonic, ataxic, intention tremor, lack of balance and coordination. A. CE. Clinical features. Patients may present with mixed types of cerebral palsy, example combination of spastic and athetoid CP. All types. Back collapse, fine text outline. Clinical features. Patients may present with mixed types of cerebral palsy, example combination of spastic and athetoid CP. All types. O. Intellectual disability, 50%. I. Copyright seizure disorder, 35%-50%. O. Upper motor neuron signs, example spasticity, hyperreflexia, clonus, copyright behavioral difficulties. O. Developmental delay, particularly motor function, example rolling over from back to belly, sitting independently, crawling. Copyright attention deficit hyperactivity disorder, spastic type. O. Muscle tone in one or more limbs. OTDTRs. O. Persistence of primitive reflexes, example positive Babinski sign, copyright toe walking or equinus deformity, copyright scissor gait, due to spastic paraplegia of the hip adductors, O muscle weakness and / or atrophy, copyright hip dislocation, copyright scoliosis, e hearing or vision impairment, scent non-spastic type O abnormal involuntary movements that worsen with stress and stop during sleep equals chorea, athetosis 1 equals dystonia 1 equals ataxia, copyright dysarthria and dysphagia. Copyright definite hand preference before 1 year of age suggests one-sided muscle weakness and is a red flag for hemiplegia. GE AE hated Hizik. Diagnostics. Diagnosis is mainly based on the clinical findings. HL** cranial ultrasonography, early neonatal period, example intracerebral hemorrhage and / or hypoxic ischemic injury, structural abnormalities MRI, in older infants to detect causative lesion, example periventricular leukomalacia, congenital malformation, intracranial hemorrhage. Differential diagnoses. Scent hypothyroid myopathy, mitochondrial myopathy, progressive muscular dystrophies, myelomeningocele, scent traumatic peripheral nerve lesions, scent genetic syndromes. The differential diagnoses listed here are not exhaustive. AOOE. Treatment. There is no curative therapy for cerebral palsy. Management is dependent on the severity and nature of symptoms. A multidisciplinary approach is employed in management to improve function and quality of life. Non-pharmacological management O physical therapy, prevents muscle contractures, copyright occupational therapy, motor skill development EO speech therapy, communication skills and dysphagia, copyright orthotic devices, example braces, splints, and casts, and assistive devices, example wheelchairs, walkers. O educational support for intellectual disability. Back collapse, fine text outline. XX cerebral palsy. Persistence of primitive reflexes, example positive Babinski sign, copyright toe walking or equinus deformity, copyright scissor gait, due to spastic paraplegia of the hip adductors, AO muscle weakness and / or atrophy, copyright hip dislocation, copyright scoliosis, copyright hearing or vision impairment, non-spastic type O abnormal involuntary movements that worsen with stress and stop during sleep equals chorea, athetosis 1 equals dystonia equals ataxia, copyright dysarthria and dysphagia. Copyright definite hand preference before 1 year of age suggests one-sided muscle weakness and is a red flag for hemiplegia. OAO. Diagnostics. Diagnosis is mainly based on the clinical findings. Cranial ultrasonography, early neonatal period, example intracerebral hemorrhage and / or hypoxic ischemic injury, structural abnormalities MRI, in older infants to detect causative lesion, example periventricular leukomalacia, congenital malformation, intracranial hemorrhage. WA. Differential diagnoses. Scent hypothyroid myopathy, mitochondrial myopathy, progressive muscular dystrophies, myelomeningocele, scent traumatic peripheral nerve lesions, genetic syndromes. The differential diagnoses listed here are not exhaustive. WA. CE. Treatment. There is no curative therapy for cerebral palsy. Management is dependent on the severity and nature of symptoms. A multidisciplinary approach is employed in management to improve function and quality of life. Non-pharmacological management, copyright physical therapy, prevents muscle contractures occupational therapy, motor skill development, copyright speech therapy, communication skills and dysphagia, copyright orthotic devices, example braces, splints, and casts, and assistive devices, example wheelchairs, walkers. O educational support for intellectual disability, copyright nutritional support for dysphagia, copyright social and psychological support, pharmacological management, copyright antispasmodics, example botulinum toxin, baclofen, dantrolene, benzodiazepines, Copyright anticonvulsants. Copyright anticholinergics for rigidity and sialorrhea. Scent surgery. Copyright orthopedic surgery to treat scoliosis and relieve contractures. Copyright selective dorsal rhizotomy to relieve spasticity. Back collapse. Fine text outline. XX teratogenesis. Teratogenesis plays an important role in neonatology and is a common cause of intellectual disability. Teratogens are environmental factors that result in permanent structural or functional malformations or death of the embryo or fetus. Many congenital malformations are of unknown origin, but known teratogens include drugs, maternal illnesses and infections, metal toxicity, and physical agents, example radiation. The fetus is most susceptible in the 3 weeks of pregnancy during organogenesis. In the embryonic period, after 8 weeks, growth and function are affected. The earlier the exposure to the teratogenic agent in utero, the more severe the defects are in the embryo/fetus. However, the individual response to teratogens is highly varied and depends on genetic susceptibility and severity of the exposure. See pharmacotherapy during pregnancy for more information on teratogenic drugs during pregnancy. See congenital torch infections for more information on teratogenic infectious agents. 7 CE. Overview. Scent teratogen, an environmental factor that causes a permanent structural or functional abnormality, growth restriction, or death of the embryo or fetus. Effects depend on multiple factors. Copyright the pharmacological properties, dose, and regimen of drug exposure determine the risk of developing teratogenic birth defects. Copyright stage of pregnancy in which exposure occurs. Overview of H of phase stage in pregnancy. Significance. Pre-implantation phase *0 to 15 days after fertilization, early embryonic period *toxicity to the developing embryo can cause spontaneous abortion, all or nothing effect. Corresponds to the period of organogenesis. 5 embryonic phase Scent first trimester SAAA most significant period for teratogenic birth defects. Period of fetal growth and maturation. Phase of fetal growth and maturation second and third trimesters can lead to deficits in organ function, intellect, behavior, or minor structural malformations. The physical effects of teratogens are widely varied. See individual conditions for specific manifestations. Ovactoral association equals vertebral, anal, cardiac, tracheoesophageal fistula, renal, and limb abnormalities. A equals due to a defect during the development of embryonic mesodermal limb deformities. Syndactyly, fusion of 2 or more fingers or toes, most common congenital malformation of the limbs, equals polymeleia/polydactyly. Supernumerary limbs, fingers, or toes in equals oligodactyly, adactyly, absence of one or more of the fingers or toes equals ectromelia, collective term for hypoplasia and/or aplasia of one or more. Long bones, resulting in limb deformity equals paromelia/paradactyly, amputation like stump of a limb, finger, or toe. WI. OE. Maternal conditions. Diabetes mellitus, pregestational diabetes mellitus or gestational diabetes mellitus. 2. Scent diabetic embryopathy. Scent diabetic fetopathy. Scent. For more information, see fetal and neonatal complications of diabetes mellitus in pregnancy. In diabetes mellitus in pregnancy. Obesity. 3. Preterm birth. Scent stillbirth. Scent neural tube defects. Scent congenital heart disease. Scent cleft lip, cleft palate. Scent limb reduction abnormalities. Macrosomia. Graves' disease. 41. Back collapse. Fine text outline. Graves' disease. 41. Scent neonatal hyperthyroidism. Scent preterm birth. Scent stillbirth. Scent intrauterine growth restriction. Scent low birth weight. Scent developmental and behavioral problems. Hypothyroidism. Scent congenital hypothyroidism. Scent congenital iodine deficiency syndrome. Phenylketonuria, maternal PKU, JASL. Scent phenylalanine embryopathy. Copyright definition, the developmental malformations in a newborn resulting from PKU during pregnancy. Copyright clinical findings equals intrauterine growth restriction equals microcephaly equals congenital heart disease equals intellectual disability equals developmental problems. Substance use during pregnancy. Alcohol, fetal alcohol syndrome, embryo fetal alcohol syndrome, 71. Epidemiology. Most common cause of teratogenic damage in children, 0.2 to 1.5 per 1,000 live births. 8. Most common preventable cause of intellectual disability in the U.S. Mechanism of teratogenesis. Scent failed neuronal and glial cell migration. Clinical findings. Scent dysmorphic features 9. Copyright thin upper lip co-smooth hypoplastic philtrum o downslanting, short palpebral fissures o hypertelorism o microcephaly. Copyright epicanthal folds. Copyright receding chin e features of specific systemic defects o heart defects, mainly ventricular septal defect, o heart-lung fistulas. Copyright skeletal anomalies, limb dislocations, joint contractures, pectus excavatum/pectus carinatum, o holoprosencephaly, a developmental field defect in which the forebrain fails to divide into two hemispheres, resulting in fusion of ventricles, leading to the formation of monoventricle, and other bilateral cerebral structures. Example basal ganglia. 10 most commonly occurs during the 3 to 4 week of pregnancy. 17 equals potential genetic causes include mutations in SHH gene coding for sonic hedgehog protein equals trisomy. 13 equals associated clinical features equals craniofacial abnormalities, cyclopia, cleft lip/palate, hypotelorism and/or proboscis. Endocrine disorders related to pituitary dysfunction, example diabetes insipidus. Equals seizures and epilepsy. Copyright renal anomalies, aplastic/dysplastic kidneys, leading to hypertension o prenatal or postnatal growth retardation. Short stature. Scent other hyperactivity. Copyright intellectual disability, example impaired language development, learning disabilities, memory deficits, and subsequent problems in social interactions and school performance. Back collapse. Fine text outline. Scent differential diagnoses EO Down syndrome. Copyright Fragile X syndrome. Copyright Williams syndrome. Cigarette smoking during pregnancy, 2-13. Mechanism of teratogenesis. Copyright nicotine, T-catecholamine release. Vasoconstriction of uteroplacental blood vessels. Compromised blood flow and oxygen delivery to the fetus. Copyright carbon monoxide, TCOHB causes tissue hypoxia. Scent affects O intrauterine growth restriction. Copyright low birth weight O increased risk of preterm labor and miscarriage, example due to placental abnormalities such as placental abruption. Copyright attention deficit hyperactivity disorder, ADHD, and conduct disorder. Copyright sudden infant death syndrome, SIDS, copyright cleft lip and palate. Opioids. Plus mechanism of teratogenesis, 41. Copyright not entirely understood. Copyright altered levels of neurotransmitters, norepinephrine, dopamine, and serotonin, are believed to play a role. Scent effects. O respiratory depression. O neonatal abstinence syndrome. Copyright intrauterine growth restriction. Copyright low birth weight. O fetal dysgenesis. Copyright placental abruption. Cocaine, 15. Mechanism of teratogenesis. Cocaine vasoconstriction of the uteroplacental vessels. Compromised blood flow and oxygen delivery to the fetus. Degree effects. Copyright intrauterine growth retardation. O low birth weight. O preterm labor. Copyright placental abruption. GVU. CE. Medications. The following drugs are no longer approved for clinical use. See pharmacotherapy during pregnancy for a comprehensive list of teratogenic drugs. Diethylstilbestrol, 16. Previous use, a synthetic estrogen that is primarily used to prevent miscarriages in expectant mothers. Scent effects. Copyright vaginal clear cell adenocarcinoma. Copyright congenital anomalies of the Milroy duct. Thalidomide, 171. Previous use, a sedative that is used to treat nausea or vomiting in pregnant women, now administered in limited indications, example multiple myeloma. Scent effects, thalidomide embryopathy. Asymmetrical amelia, complete absence of limbs, omicr amelia, flipper limbs. Copyright anotia, absence of the external ear. Copyright phocomelia, a teratogenic limb defect that is characterized by the absence of the proximal portion of a limb, hand or foot are directly attached to the shoulder or hip. _DHALIM causes limb defects. Back collapse. Fine text outline. Physical agents. Radiation exposure during pregnancy. Scent etiology, radiation exposure from X-ray, CT, and/or nuclear medicine imaging. 18E pathophysiology, chromosomal damage or cell death. Scent effects. Microcephaly. Copyright intellectual disability. Intrauterine growth restriction. Malignancy. S. Metal toxicity. Lead 19. Scent etiology, maternal lead poisoning, blood Pb equals 50 Tg/dl, scent effects. Spontaneous abortion. Copyright stillbirth. Hemangiomas, lymphangiomas, hydroceles, skin tags, undescended testes. Copyright Vactoral 20. Mercury 21. Scent etiology, methyl mercury, can be found in contaminated seafood, especially tilefish, swordfish, shark, and king mackerel. Scent effects. Copyright cerebellar atrophy. Copyright atrophy of the visual brain cortex. Copyright polyneuritis. VA. KO, Cs. Conditions associated with congenital cardiac defects. Overview of conditions. I with ital cardiac condition. Ajat ital cardi. Transposition of great vessels. VSD. Maternal conditions. Maternal diabetes. *PDA pulmonary artery stenosis. VSD plus ASD infection. Congenital rubella plus VSD PDA ASD. Tetralogy of Fallot. Alcohol use, fetal alcohol syndrome, substances/drugs. Prenatal lithium exposure. Epstein anomaly. ASD. Down syndrome. VSD plus AV. Septal defect, endocardial cushion defect. MVP. Marfan syndrome. Thoracic aortic aneurysm/aortic dissection. Aortic regurgitation. Hereditary conditions. Bicuspid aortic valve *. Coarctation of aorta. Turner syndrome. Williams syndrome. Supravalvular aortic stenosis. Truncus arteriosus. Tetralogy of Fallot. 22q11.2 microdeletion, DeGeorge syndrome. Back collapse. Fine text. Defect. O. Outline. Syndactyly. VV. Fusion of two fingers of a newborn's right hand. Syndactyly is the most common congenital malformation of the limbs. Source: newborn boy showing complete complex syndactyly with two fingers right hand. JPG, GLIU, Wikimedia Commons licensed under public domain. Overlay. Central polydactyly. X-ray left hand, PA view, of a 10-year-old child. There is central polydactyly, with duplication of the third, middle, finger metacarpals and phalanges, green overlay. Source: X-ray of type 3 central polydactyly, the middle fingers are the same length. By Drunu 23, Wikimedia Commons, licensed under CC by 3.0. Further notes: subsequent alterations made by Wikimedia Commons users Grendel Khan, Rahul 654, and Solipsist. Uroteratogenesis, 1/3. Narrow forehead. Hypertelorism equals epicanthal folds 0068 down slanting, Short $5 palpebral fissures SEEY leaky railroad track ears a smooth hypoplastic philtrum. Thin upper lip SY. Receding chin /we. Clinical findings in fetal alcohol syndrome. Copyright emboss. And normal. Teratogenesis, 2/3. Types of holoprosencephaly. Copyright emboss. SSO. Semi-lobar holoprosencephaly. MRI head, flare-weighted, axial plane, of a 12-month-old boy with global developmental delay, irregular sleep patterns, and poor weight gain. There is incomplete forebrain division, with the cerebral lobes differentiated posteriorly but remaining fused anteriorly. The lateral ventricles are also fused. Source, Fig 1, in Semi-lobar holoprosencephaly in a 12-month-old baby boy born to a prima gravida patient with type 1 diabetes mellitus, a case report by Palangio P., Limo F., Nicolas P., Makungu H., Mdalara M., Manya, BMC, Journal of Medical Case Reports, licensed under CC by 4.0. Modifications, numbers and arrows removed. X. Congenital torch infections. Congenital infections are caused by pathogens transmitted from mother to child during pregnancy, transplacentally, or delivery, peripartum. They can have a substantial negative impact on fetal and neonatal health. The acronym TORCH stands for the causative pathogens of congenital infections, Toxoplasma gondii, others, including Treponema pallidum, Listeria, Varicella zoster virus, and Parvovirus B19, Rubella virus, cytomegalovirus, CMV, and herpes simplex virus, HSV. Torch infections can cause spontaneous abortion, premature birth, and intrauterine growth restriction, IUGR. These infections can also cause abnormalities in the CNS, the skeletal and endocrine systems, and the complex organs, example cardiac defects, vision, and hearing loss. Prophylaxis is of great importance during pregnancy. Primary prevention includes vaccination for varicella and rubella, prior to pregnancy, hygiene measures, washing hands and avoiding certain foods, and screening for syphilis. During pregnancy, affected infants require regular follow-ups to monitor for hearing loss, ophthalmological abnormalities, and developmental delays. Several other pathogens can also be vertically transmitted during pregnancy and have detrimental effects on the fetus and/or newborn. These include HIV in pregnancy, perinatal hepatitis B, group B streptococci, E. coli, gonococcal infections, and chlamydial infections, West Nile virus, Zika virus, measles virus, enterovirus, and adenovirus. The pathogens are discussed in more detail in their respective articles. WA. Fe. CES. Overview. Description. Congenital torch infections are vertically transmitted infections, acquired directly from the mother and transmitted to the embryo, fetus, or newborn through the placenta or birth canal, that are capable of significantly influencing fetal and neonatal morbidity and mortality. Scent toxoplasmosis scent others, example syphilis, varicella, parvovirus B19 infection, listeriosis, scent rubella cytomegalovirus, CMV, herpes simplex virus, HSV, infection. Common findings. Scent during pregnancy may cause intrauterine fetal demise and miscarriage in neonates. O hepatosplenomegaly e jaundice o lethargy o growth retardation copyright thrombocytopenia. Overview of ital torch eye infection clinical features diagnosis treatment prevention. Asterisk classic triad copyright chorioretinitis 7. Asterisk avoidance of uncooked meat asterisk T. gondii specific IgMPA2. 7e degree hydrocephalus asterisk pyrimethamine, sulfadiazine, asterisk avoidance of handling cat feces toxoplasmosis, antibodies ES, A. Copyright diffuse intracranial calcifications, ring and folinic acid * immediate administration of spiramycin to equals, sent PCR for T-Gondi DNA enhancing lesions, prevent fetal toxoplasmosis petechiae and purpura, blueberry muffin rash. Early congenital syphilis, onset 2 years, *PCR. Copyright frontal bossing, Brigades copyright Hutchinson teeth copyright interstitial keratitis copyright sensorineural deafness copyright saber shins. Spontaneous abortion and premature birth meningitis, sepsis vesicular and pustular skin lesions, 1 cent PTI. Avoidance of unpasteurized dairy products avoidance of cold deli meats listeriosis bacterial culture ampicillin and gentamicin. IUGR, premature birth chorioretinitis, cataract direct fluorescent antigen varicella zoster immune encephalitis test, DFA, globulin, VZIG, PCR for VZV DNA acyclovir serology, IgM antibodies, breastfeeding. Active immunization of mother before varicella zoster virus, VZV, pregnancy pneumonia passive immunization with VZIG1 CNS abnormalities hypoplastic limbs. PCR for parvovirus B19 aplastic anemia DNA fetal hydrops serial ultrasounds to rule transfusion if indicated out fetal hydrops. Back collapse fine text outline. Frequent hand washing intrauterine fetal blood avoid potentially contaminated workplaces, example schools, pediatric clinics, parvovirus B19. IUGR sensorineural deafness A, plus cataracts heart defects, example PDA, pulmonary artery stenosis, *CNS abnormalities plus petechiae and purpura, blueberry muffin rash. Rubella PCR for rubella RNA. Jaundice, hepatosplenomegaly *IUGR chorioretinitis. Viral culture PCR for CMV DNA us CMV, plus P calcifications petechiae and purpura, BLE microcephaly seizures. Scent premature birth, IUGR skin, eyes, and mouth involvement, vesicular herpes simplex virus lesions, keratoconjunctivitis localized CNS involvement, meningoencephalitis multiple organ involvement, sepsis. Viral culture PCR for HSV DNA. Serology, IgM antibodies, scent supportive care. Ganciclovir and valganciclovir supportive care. Plus acyclovir scent supportive care. Active immunization of mother before pregnancy. Second immunization of mother after delivery if serologic titers remain negative. Frequent hand washing avoid potentially contaminated workplaces, example schools, pediatric clinics. Caesarean delivery if lesions are present at delivery. Transplacental transmission occurs following primary infection of a seronegative mother during pregnancy. Maternal IgM antibodies, which are unable to cross the placenta, form first. Protective IgG antibodies, which are able to cross the placenta, have not yet been formed, so the infant is not protected from infection via the placenta. Attenuated live vaccines, measles, mumps, rubella, and varicella, are contraindicated in pregnancy. Conception should be avoided for 1 month after immunization with live vaccines. In general, the earlier in pregnancy a torch infection occurs, the more severe the complications. 2. Congenital toxoplasmosis. Epidemiology. 0.5-1:10,000 live births per year in the US2. Pathogen. Toxoplasma gondii. Transmission. Mother o cat feces o raw or insufficiently cooked meat o unpasteurized milk, especially goat milk, copyright see etiology in toxoplasmosis. Fetus copyright transplacental transmission equals first trimester, 15% equals third trimester, 70%. Clinical features 3. Scent first trimester. Increased risk of premature birth and spontaneous abortion. Copyright classic triad of toxoplasmosis. Chorioretinitis, a form of posterior uveitis, equals diffuse intracranial calcifications equals hydrocephalus. Copyright possible other nonspecific clinical features equals petechiae and purpura, blueberry muffin rash, equals fever. A. Find text. O. Outline. Copyright possible other nonspecific clinical features petechiae and purpura, blueberry muffin rash, _ fever jaundice hepatosplenomegaly lymphadenopathy pneumonitis seizures macrocephaly or microcephaly 41 thrombocytopenia scent second or third trimester, subclinical or mild toxoplasmosis sequelae of congenital toxoplasmosis, O epilepsy. Copyright intellectual disability. Copyright visual disabilities, chorioretinitis increased risk of chorioretinal scars, cataracts, and glaucoma. E sensorineural hearing loss. Diagnostics 5. Scent mother, see diagnostics in toxoplasmosis. Fetus, PCR for T. gondii DNA in amniotic fluid, newborn OCT/MRI, intracranial calcifications, hydrocephalus, ring-enhancing lesions. Copyright T. gondii specific IgM antibodies, CSF, serum, copyright PCR Fort. Gondii DNA, CSF, serum, copyright ophthalmological evaluation, chorioretinitis. Treatment, 51. Scent mother, immediate administration of spiramycin to prevent fetal toxoplasmosis. J6 scent fetus, when confirmed or highly suspected, switch to pyrimethamine, sulfadiazine, and folinic acid. Scent newborn, pyrimethamine, sulfadiazine, and folinic acid. Prevention 31. Avoid raw, undercooked, and cured meats. Wash hands frequently, especially after touching soil, example during gardening. Scent avoid contact with cat litter. And B. The 4 Cs of congenital toxoplasmosis, cerebral calcifications, chorioretinitis, hydrocephalus, and convulsions. Y. AE. Congenital syphilis. Epidemiology. 23,100,000 live births per year in the U.S. 1/7. Pathogen. Treponema pallidum. Transmission 71. Scent mother. Copyright sexual contact, contact with infectious lesion, OC etiology in syphilis. Scent fetus, transplacental transmission from infected mother. Degree increased risk of transmission with recent syphilis infection. Copyright risk of transmission increases with gestational age. A. Find text. O. Outline. Scent fetus, transplacental transmission from infected mother. Copyright increased risk of transmission with recent syphilis infection. Copyright risk of transmission increases with gestational age. Scent neonate, perinatal transmission during birth. Clinical features of congenital syphilis 8. Scent in utero syphilis. O miscarriage. Copyright stillbirth. O hydrops fetalis. Early congenital syphilis, onset 2 years of age. Copyright typical facial features, saddle nose, frontal bossing, short maxilla. Copyright dental findings, Hutchinson's teeth, notched, widely spaced teeth, mulberry molars, poorly developed first molars, 5 eyes and ears equals syphilitic keratitis, non-ulcerative, interstitial keratitis that develops as a late complication of syphilis equals more common in patients with congenital syphilis than acquired syphilis equals causes stromal inflammation. Sensorineural hearing loss. Copyright skin, regades, perioral fissures, cracks, and slash or scars, particularly near the corners of the mouth and nose. Degree skeletal equals saber shins anterior bowing of the tibia, causing it to resemble a saber equals other causes include rickets and Paget disease of bone. Painless arthritis in knees and other joints. Copyright neurological, cranial nerve palsies, example CN8 defect causing deafness, intellectual disability, hydrocephalus. Diagnosis, 1 degree. Mother, see diagnostics of syphilis in pregnancy. Fetus, repeated ultrasound examinations, placentomegaly, hepatomegaly, ascites, and/or hydrops fetalis, ch neonate ORPR or VDRL, serum, copyright dark field microscopy or PCR of CSF. Copyright CBC and differential. Copyright radiographs of the long bones. Further studies depend on clinical features of congenital syphilis. Treatment. Plus neonates, 10 days of 4 penicillin G, 9 mothers. Treatment depends on whether diagnosed prenatally or postnatally. OC treatment of syphilis in pregnancy and treatment of syphilis. Prevention, 71. Prenatal screening for syphilis and, if positive, antibiotic treatment, should take place in early pregnancy because placental transmission is most likely to occur after the first trimester. Sent nationally notifiable condition, congenital syphilis and syphilitic childbirth must be reported to the local or state health department. And Hutchinson triad, interstitial keratitis, sensorineural hearing loss, Hutchinson teeth. Back collapse. Fine text outline. Congenital listeriosis. Epidemiology. 3:100,000 live births per year in the U.S., 1. Pathogen. Listeria monocytogenes. Transmission, 121. E-mother. Copyright contaminated food, especially raw milk products. Copyright other possible sources, fish, meat, and industrially processed vegetables, example ready-made salads. Copyright see etiology in listeriosis. Sent fetus. Transplacental transmission from an infected mother. Copyright direct contact with infected vaginal secretions and/or blood during delivery. Clinical features, 131. Sent listeriosis of pregnancy. Copyright increased risk of premature birth and spontaneous abortion. Early onset syndrome, granulomatosis infantiseptica equals severe systemic infection characterized by disseminated abscesses, may develop in any organ system, equals most common findings, respiratory distress and skin lesions equals signs of meningitis may already develop. Sent neonatal listeriosis. Late onset syndrome, 5 days to 3 weeks after birth. Listeria meningitis/encephalitis. OC neonatal infection. Diagnosis. Culture from blood or CSF samples, pleocytosis. 14 treatment. 4 ampicillin and gentamicin, for both mother and newborn, 14 prevention, 12. Avoidance of soft cheeses. Avoidance of potentially contaminated water and food. Nationally notifiable condition, listeriosis must be reported to the local or state health department. EC food and water safety. WA 05. Congenital varicella infection. Epidemiology. Sent seroprevalence in the general population is 95%. 15 Most mothers have been vaccinated, so congenital infection is rare. Varicella zoster virus, VZV. Transmission, 61. Sent mother. Copyright primary infection, equals airborne droplets equals direct skin contact with vesicle fluid. Reactivation, usually in immunocompromised individuals. Copyright see chickenpox and shingles. Sent fetus, transplacental transmission from an infected mother. Clinical features, 16. Sent congenital varicella syndrome, infection during first and second trimester, 17. Hypertrophic scars, cicatricial skin lesions, limb defects, example hypoplasia. Back collapse. Fine text outline. Clinical features, 16. Sent congenital varicella syndrome, infection during first and second trimester, 17O hypertrophic scars, cicatricial skin lesions, O limb defects, example hypoplasia, copyright ocular defects, example chorioretinitis, cataracts, microphthalmia, OCNS defects, example cortical atrophy, seizures, intellectual disability, hydrocephalus and neonatal varicella copyright mild infection, maternal exanthem 5 days before birth, copyright severe infection, maternal exanthem. Diagnosis, 161. Sent newborn and mother copyright usually clinical diagnosis is confirmed by appearance of skin lesions ODFA or PCR of fluid collected from blisters or cerebrospinal fluid, CSF, copyright serology for sent fetus, PCR for VZV DNA, in fetal blood, amniotic fluid, and ultrasound to detect fetal abnormalities. Treatment, 161. Sent for pregnant women or newborns with severe infection, acyclovir administer post-exposure prophylaxis in newborns if mother displays symptoms of varicella. Sent immunization of seronegative women before pregnancy. Sent VZIG in pregnant women without immunity within 10 days of exposure. Sent nationally notifiable condition, varicella must be reported to the local or state health department. WA. A6. Congenital parvovirus B19 infection. Epidemiology, 9. 5% incidence in pregnant women per year in the USA. Higher prevalence in daycare workers and elementary school teachers. Pathogen. Sent parvovirus B19 mechanism of action, infection of erythrocyte progenitor cells in bone marrow and endothelial cells by attaching to their P antigen. Cell destruction. Hydrops fetalis in neonates and pure RBC aplasia in adults. Transmission. Sent mother O mainly via aerosols O rarely hematogenous transmission OC. Fifth disease. Sent fetus, transplacental transmission from infected mother. Clinical features 19. Sent severe anemia and possibly fetal hydrops. Sent fetal demise and miscarriage/stillbirth in approximately 10% of cases, risk is highest in the first and second trimesters. Sent most intrauterine infections do not result in fetal developmental defects. Diagnosis. Sent mother, serologic assays for IgG and IgM against parvovirus B19. Serologic assay analysis for parvovirus B19 results positive IgM, negative IgM *, acute infection. Sent maternal immunity, positive IgG RCS, sent refer to specialist. Reassurance. Very recent infection, no maternal immunity, negative IgG PUS, sent refer to specialist, * counseling. Back collapse, fine text outline. Plus fetus, 19O PCR for parvovirus B19 DNA, amniotic fluid or blood, copyright periodic ultrasound of fetal vessels for anemia, land hydrops fetalis, every 1 to 2 weeks, copyright in cases of suspected anemia according to Doppler ultrasound, fetal hemoglobin levels are determined via the umbilical vein. Treatment. Sent intrauterine fetal blood transfusion in cases of severe fetal anemia. Sent additional platelet transfusion if thrombocytopenia is also present. Prevention. Sent hand hygiene, frequent hand washing. Sent pregnant women with risk factors for torch infection should avoid potentially contaminated workplaces, example schools, pediatric clinics. WA. CE. Congenital rubella infection. Epidemiology. Most mothers have been vaccinated, so congenital infection is very rare. 20 Pathogen. Rubella virus. Transmission. Sent mother O mainly via airborne droplets OC rubella. Sent fetus copyright transplacental from infected mother. Copyright risk of fetal infection is high in the first trimester, decreased in the second trimester and then increased again in the third trimester. 21 Copyright risk of congenital rubella syndrome 221 equals 1 to 12 weeks gestation, period of organogenesis highest risk equals 12 to 20 weeks gestation, very low equals 20 weeks gestation, no documented cases. Clinical features 221. Scent intrauterine rubella infection, miscarriage, preterm birth, fetal growth restriction, especially likely if infection occurs during the first trimester. Scent congenital rubella syndrome copyright triad of congenital rubella syndrome equals cardiac defect, most common defect, example patent ductus arteriosus, pulmonary artery stenosis, equals cataracts. Other eye manifestations may also occur later in life, including glaucoma and salt and pepper retinopathy, abnormal retinal pigmentation, equals cochlear defect, bilateral sensorineural hearing loss. Early features equals hepatosplenomegaly, jaundice equals hemolytic anemia, thrombocytopenia equals petechiae and purpura, i.e., blueberry muffin rash, due to extramedullary hematopoiesis in the skin, transient meningitis and/or encephalitis equals pneumonia. Late features equals CNS defects, microcephaly, intellectual disability, panencephalitis equals skeletal abnormalities equals endocrine disorders, example diabetes, thyroid dysfunction, equals vascular disease, equals immune defects. Diagnosis 23. Scent newborn and mother OPCR for rubella RNA, throat swab, CSF, copyright serology, abnormally high or persistent concentrations of IgM and/or IgG antibodies, copyright viral culture, nasopharynx, blood. Back collapse fine text outline. E-fetus. Scent fetus copyright IgM antibody serology, chorionic villi, amniotic fluid, copyright PCR for rubella RNA, chorionic villi, amniotic fluid. Treatment. Plus intrauterine rubella infection 23 copyright 16 weeks, reassurance and symptomatic therapy, example acetaminophen, scent congenital rubella syndrome, supportive care, based on individual disease manifestations, and surveillance, including monitoring for late-term complications. Prevention 24. Scent immunization of seronegative women before pregnancy. Scent nationally notifiable condition, suspected congenital rubella syndrome must be reported to the local or state health department. BNBCCC triad of congenital rubella syndrome, cataracts, cochlear defects, cardiac abnormality. 7. CES. Congenital CMV infection. Overview. Epidemiology. 0.5 to 1% of live births per year in the U.S. 25 pathogen. Cytomegalovirus transmission. Scent mother, via CMV contaminated blood, urine, saliva, and genital secretions. Copyright blood transfusions. Sexual transmission. Copyright droplet transmission. Copyright transplant transmitted infection, example bone marrow, lungs, kidneys, cytomegalovirus infection. Fetus, transplacental transmission from an infected mother, scent newborn, during birth or postnatal via breast milk from infected mother. Clinical features 26. Scent fetal infection. Copyright increased risk of fetal demise. OIUGR. Copyright oligohydramnios or polyhydramnios, placental abnormalities. Scent newborn infection. Copyright severity *. Subclinical infection, 90% 10% go on to develop a late complication, most commonly hearing loss, 26 equals symptomatic infection at birth, 10% 70 to 80% go on to develop a late complication. Copyright CNS findings equals hydrocephalus equals microcephaly. Copyright sensorineural hearing loss, 30%. 127 Copyright chorioretinitis, 10%. Copyright nonspecific findings, similar to other torch infections, petechiae, purpura, blueberry muffin rash, equals hepatosplenomegaly, jaundice equals small for gestational age, SGA, equals seizures, lethargy, poor suck equals hemolytic anemia, thrombocytopenia equals pneumonia late complications equals hearing loss, vision impairment equals psychomotor retardation, intellectual disability equals dental abnormalities 5. Diagnosis, 28 I1 I29. Back collapse find text outline. E. Diagnosis. Sent fetus and newborn ECNS imaging, hydrocephalus, periventricular calcifications or intraventricular hemorrhage O ultrasound, periventricular calcifications, hyperechogenic foci, bowel and liver, ascites, and hydrops fetalis sent newborn and mother EOCMV IgM antibodies, blood, O viral culture or PCR for CMV DNA, urine, saliva, sent fetus copyright viral culture or PCR for CMV DNA, amniotic fluid, copyright CMV IgM antibodies, fetal blood. Differential diagnosis 28. Sent congenital toxoplasmosis copyright causes chorioretinitis, hydrocephalus, and intracranial calcifications copyright intracranial calcifications in congenital toxoplasmosis typically show ring enhancement. Treatment. Fetus severe anemia, intrauterine blood transfusions copyright thrombocytopenia, platelet transfusions newborn supportive therapy of symptoms, example fluid and electrolyte imbalances, anemia, thrombocytopenia, seizures, secondary infections, copyright ganciclovir, valganciclovir or foscarnet sent mother, valacyclovir is the only therapy approved during pregnancy 30 prevention. Frequent hand washing, especially after contact with bodily secretions of small children, example diaper changing, scent avoidance of food sharing with children avoidance of kissing small children on the mouth. Copyright congenital toxoplasmosis may manifest with symptoms resembling congenital CMV infection. VA. CE. Congenital herpes simplex virus infection. Epidemiology. 1:3,000-10,000 live births per year 81. Pathogen. Mainly herpes simplex virus 2, HSV2, in rare cases HSV1. Transmission 311. Sent mother copyright primary infection, contact with contaminated oral secretions via small skin lesions or reactivation, usually in immunocompromised individuals OC herpes simplex virus infections. Fetus, transplacental transmission from an infected mother, rare, sent newborn, perinatal transmission during birth, 30% transmission rate if mother has not yet undergone seroconversion at time of delivery, clinical features 32. Sent intrauterine HSV infection, 5% of cases, O fetal demise, preterm birth, very low birth weight copyright microcephaly, hydrocephalus, and other CNS defects degree microphthalmia and chorioretinitis copyright vesicular skin lesions sent perinatal and postnatal transmission O skin, eye, and mouth disease equals vesicular skin lesions V. Back collapse find text outline. OOOE. Congenital herpes simplex virus infection. Epidemiology. 1:3,000-10,000 live births per year 81. Pathogen. Mainly herpes simplex virus 2, HSV2, in rare cases HSV1. Transmission 31. Sent mother copyright primary infection, contact with contaminated oral secretions via small skin lesions OE reactivation, usually in immunocompromised individuals EC herpes simplex virus infections. Sent fetus, transplacental transmission from an infected mother, rare, newborn, perinatal transmission during birth, 30% transmission rate if mother has not yet undergone seroconversion at time of delivery, CA clinical features 321. Sent intrauterine HSV infection, 5% of cases, O fetal demise, preterm birth, very low birth weight 1 copyright microcephaly, hydrocephalus, and other CNS defects copyright microphthalmia and chorioretinitis copyright vesicular skin lesions sent perinatal and postnatal transmission copyright skin, eye, and mouth disease vesicular skin lesions keratoconjunctivitis leading to cataracts, chorioretinitis vesicular lesions of oropharynx OCNS disease meningoencephalitis, manifesting with fever, lethargy, irritability, poor feeding, seizures, bulging fontanelle, equals possibly vesicular skin lesions copyright disseminated disease features similar to those of sepsis, with organ involvement, example liver, CNS, lungs, heart, adrenal glands, kidneys, GL tract, vesicular skin lesions, may not appear until late in disease course. Diagnosis. Sent mother, typically a clinical diagnosis fetus, the ultrasound may show CNS abnormalities. Newborn, perform neonatal HSV testing. Copyright standard, viral culture of HSV from skin lesions, conjunctiva, oro/nasopharynx, or rectimo alternative, PCR for HSV DNA, CSF, blood. Treatment 33. Sent newborn and mother, for acyclovir or valacyclovir, 1, sent additionally in newborns, supportive therapy of fluid/electrolyte imbalances, SIRS, septic shock, seizures, secondary infections, etc. Prevention of neonatal HSV infection 341. Plus antiviral therapy, acyclovir, beginning at 36 weeks of gestation for individuals with a known history of HSV lesions 1 * cesarean delivery in women with active genital lesions or prodromal symptoms, example burning pain, 1. HSV should be considered in infants up to 6 weeks of age with vesicular skin lesions, persistent fever with negative cultures, and/or symptoms of meningitis, encephalitis, or sepsis. 6. Skin, eye, and mouth disease caused by HSV has a good prognosis if detected and treated early. 8 shared no. Sources. Last updated October 19, 2023. Back collapse fine text outline. Infection of cells, e.g. muscle cells, equals and development of B. bradyzoite-filled cyst, thus progressing to chronic stage release of sporozoites. Tachyzoites. Tachyzoid. / infection of a cell and asexual reproduction I. Potential placental colonization and transplacental transmission A. Life cycle of Toxoplasma gondii. Extraintestinal phase intermediate host. Sporulation of oocysts into the environment. Release of sporozoites. A tachyzoid. Tachyzoites. 1 Mepian. Infection of epithelial cells and asexual reproduction. Release of oocysts into feces release of bradyzoites. Gametocytes X develop into oocysts. Development O sexual forms, gametocytes. Enteroepithelial phase definitive host. The life cycle of toxoplasmosis involves transmission to a human host through the ingestion of cat feces particulate that contains oocysts or ingestion of meat, i.e., pork, containing toxoplasma cysts. Cross-placental transmission is possible after the initial infection of pregnant women. Copyright Boss. Urocongenital torch infections, 2/5. Blueberry muffin syndrome. Newborn with acute myeloid leukemia, AML, multiple bluish-purple macules and nodules are distributed across the face and scalp, with a few extending onto the torso. Jaundice is also present. This appearance is termed blueberry muffin syndrome. Differential diagnoses include hematological disorders, other malignancies, and congenital infections. The jaundice in this case may be related to the underlying AML but is not part of the blueberry muffin appearance itself. Source: Fig 1, in, Case Report, Blueberry Muffin Syndrome by Ben Miloud S., El Hadoji, Alaki Belgidizi, Hida M., Buharo A., Pan-African Medical Journal, licensed under CC by 2.0. Overlay. Congenital toxoplasmosis. Cranial CT scan of an infant. For contrast, axial view, the left lateral ventricle is highly dilated, hatched red overlay. Hyperdensities are visible in the parenchyma of the right frontal lobe, green overlay, and in the occipital lobe, green overlay, white arrow, indicating parenchymal calcifications. Hydrocephalus, ventriculomegaly, and parenchymal calcifications are typical radiological features of congenital toxoplasmosis. Source: Figure 1 in, Congenital toxoplasmosis presenting as central diabetes insipidus in an infant, a case report by Mohammed S., Osman A., Al-Jurayan N.A., Al-Nemri A., Soleh Ahmad, BMC Research Notes, licensed under CC by 2.0. Overlay. Congenital toxoplasmosis. Cranial CT scan of an infant. For contrast, axial view, the left lateral ventricle is highly dilated, hatched red overlay. Hyperdensities are visible in the parenchyma of the right frontal lobe, green overlay, and in the occipital lobe, green overlay, white arrow, indicating parenchymal calcifications. Hydrocephalus, ventriculomegaly, and parenchymal calcifications are typical radiological features of congenital toxoplasmosis. Source: Figure 1 in, Congenital toxoplasmosis presenting as central diabetes insipidus in an infant, a case report by Mohammed S., Osman A., Al-Jurayan N.A., Al-Nemri A., Soleh Ahmad, BMC Research Notes, licensed under CC by 2.0. Overlay. Internal capsule lesion in neurotoxoplasmosis. MRI head, T2 weighted, with contrast, axial plane, of a patient with cerebral toxoplasmosis. A small nodule, hatched overlay, in the right internal capsule is accompanied by hyperintense paralesional edema, solid overlay. Neurotoxoplasmosis more commonly manifests with multiple lesions and it has a propensity for the corticomedullary junction, thalami, and basal ganglia. It is a leading cerebral opportunistic infection in patients with AIDS. Source: Intracranial toxoplasmosis 001.jpg by Prashant Sadala, Wikidoc, licensed under CC by SA 3.0. Overlay. Internal capsule lesion in neurotoxoplasmosis. MRI head, T2 weighted, with contrast, axial plane, of a patient with cerebral toxoplasmosis. A small nodule, hatched overlay, in the right internal capsule is accompanied by hyperintense paralesional edema, solid overlay. Neurotoxoplasmosis more commonly manifests with multiple lesions and it has a propensity for the corticomedullary junction, thalami, and basal ganglia. It is a leading cerebral opportunistic infection in patients with AIDS. Source: Intracranial toxoplasmosis 001.jpg by Prashant Sadala, Wikidoc, licensed under CC by SA 3.0. Urocongenital torch infections, 2/4. Skin alterations in congenital syphilis VV. Plantar surfaces of the feet in a newborn with congenital syphilis. The right foot shows a fluid-filled blister. The left foot shows a blister that has already peeled. These features suggest pemphigus syphiliticus, which is pathognomonic for congenital syphilis. Source: Copyright IMPP. Urocongenital torch infections, 3/4. Hutchinson's teeth resulting from congenital syphilis VV. The central incisor teeth are narrow and notched, Hutchinson teeth, while the molars are not fully developed, mulberry molars. These findings occur after continued inflammation and scar formation through congenital syphilis. Source, ID #, 2385, Susan Lindsley, Centers for Disease Control and Prevention licensed under public domain. Further notes, Public Health Image Library, Phil, ID, 2385. Urocongenital torch infections, 4/4. Spirochetes on dark field microscopy. Photomicrograph of rabbit testicular tissue, dark field microscopy combined with immunofluorescence, 54x magnification. Spiral bacteria are visible, which is the characteristic appearance of spirochetes. Source, 2335, CDC/CW Hubbard, Centers for Disease Control and Prevention's Public Health Image Library licensed under public domain. Overlay. Morganian, hypermature, cataract VV. Slit lamp photography. The completely opacified lens is visible in the pupil. Its darker, inferior part represents the sunken nucleus, blue overlay, within the liquefied cortex, white upper part, yellow overlay. This is the typical appearance of Morganian hypermature cataract. The anterior chamber shows deposits, probably macrophages filled with lens protein, examples indicated by arrowheads. This suggests a phacocytic process, which, if left untreated, can lead to phacolytic glaucoma. Hatched overlay, optical cross-section of the cornea, produced by slit lamp. Source, copyright IMPP. Congenital torch infections, 1/1. Y/Y. Copyright. Overlay. Morganian, hypermature, cataract VV. Slit lamp photography. The completely opacified lens is visible in the pupil. Its darker, inferior part represents the sunken nucleus, blue overlay, within the liquefied cortex, white upper part, yellow overlay. This is the typical appearance of Morganian hypermature cataract. The anterior chamber shows deposits, probably macrophages filled with lens protein, examples indicated by arrowheads. This suggests a phacocytic process, which, if left untreated, can lead to phacolytic glaucoma. Hatched overlay, optical cross-section of the cornea, produced by slit lamp. Source, copyright IMPP. TIW 0.2 MI 0.38 C8-5 WETL/COP build 53 7.8 cm. Overlay. Congenital CMV infection. Ultrasound of the CNS, parasagittal section, dilated lateral ventricles with hyperechoic deposits that are compatible with intraventricular hemorrhage. Source, copyright IMPP. TIW 0.2 MI 0.38 C8-5 WCHTL/COP build 53 7.8 cm. Congenital CMV infection. Overlay. Ultrasound of the CNS, parasagittal section, dilated lateral ventricles with hyperechoic deposits that are compatible with intraventricular hemorrhage. Source, copyright IMPP. TIW 0.1 MI 0.39 C8-5 WCHTL/COP build 234 8.8 cm. Overlay. Congenital CMV infection. Ultrasound of the CNS, coronal section, dilated lateral ventricles with hyperechoic deposits that are compatible with intraventricular hemorrhage, green areas. Arrow equals periventricular calcification. Source, copyright IMPP. TLW 0.1 MI 0.39 C8-5 WCHTL/COP build 234 8.8 cm. A 3/10 degree. Overlay. Congenital CMV infection. Ultrasound of the CNS, coronal section, dilated lateral ventricles with hyperechoic deposits that are compatible with intraventricular hemorrhage, green areas. Arrow equals periventricular calcification, source, copyright IMPP. X. Human immunodeficiency virus infection. Infection with the human immunodeficiency virus, HIV, leads to a complex disease pattern that ultimately results in chronic immunodeficiency. HIV can be transmitted sexually, parenterally, or vertically, example peripartum from mother to child. Infection is most common in the young adult population between 20 and 30 years of age. The virus infects macrophages and other CD4+ cells, leading to the destruction of CD4 T cells, which are one of the key mechanisms of cellular immune defense. The three major stages of HIV infection are acute infection, clinical latency, and acquired immunodeficiency syndrome, AIDS. Detailed classifications of clinical staging have been established by the Centers for Disease Control and Prevention, CDC, and the World Health Organization, WHO. During the acute infection stage, the virus reproduces rapidly in the body, which can lead to the onset of acute, nonspecific, example flu-like, symptoms, also known as acute retroviral syndrome, ARS, within 2 to 4 weeks. However, approximately half of all infected individuals remain asymptomatic. Once the acute infection stage subsides, the clinical latency stage begins. As with the acute infection stage, many individuals remain asymptomatic during this period while others develop non-AIDS defining conditions, example oral hairy leukoplakia. The last stage, AIDS, is characterized by AIDS defining conditions, such as kappa C sarcoma, and / or a CD4 count. HIV infection can be reliably detected using antigen / antibody-based tests. In patients with confirmed infection, treatment with a combination of antiretroviral medications, ART, is started as soon as possible. The effectiveness of the treatment is monitored via regular checks of CD4 count and viral load. Patients in the advanced stages of HIV infection may additionally require treatment of HIV-associated conditions and prophylaxis for opportunistic infections. Significant advances in treatment mean that the average life expectancy of HIV patients receiving ART is approaching that of the general population. Partners of HIV-positive people and individuals at high risk of HIV infection can reduce the risk of contracting the infection by taking ART prior to exposure, pre-exposure prophylaxis, or following exposure, post-exposure prophylaxis, to the virus. %. Epidemiology. Incidence, in the U.S., copyright HIV infection, peak incidence between ages 20 and 30, 35/100,000, copyright AIDS, peak incidence approximate age 45, 14/100,000, copyright ethnicity, incidence is significantly higher in the Black population than in other population groups. * Prevalence. OUS, 1.2 million for copyright global, 37 million. References, IL2I3. Epidemiological data refers to the U.S., unless otherwise specified. OO. Fe. IEEE. Etiology. Pathogen, human immunodeficiency virus. Scent family, Retroviridae scent genus, lentivirus * species. OHIV1, most common species worldwide, copyright HIV2, restricted almost completely to West Africa, scent structure, icosahedral with a conical capsid and a spiked envelope genome copyright pseudodiploid, 2 RNA molecules yielding 1 DNA molecule, copyright 9 genes encoding a total of 15 proteins scent function of structural proteins copyright pol gene codes for a polyprotein which consists of protease, cleavage of GAG and GAG pol proteins during maturation of the virion 4 reverse transcriptase, converts viral RNA to dsDNA integrase, helps insert the viral genes into the host genome. Back collapse fine text outline. Integrase, helps insert the viral genes into the host genome. Copyright GAG gene codes for GAG protein, which consists of equals matrix protein, P17 protein, equals nucleocapsids equals capsid proteins, P24 capsid protein. Copyright ENV gene codes for GP160 which gets cleaved into envelope glycoproteins equals GP120, attaches to host CD4 plus T cells equals GP41, assists in fusion and entry of the virus into the host cell. Copyright TAT gene, transactivator of transcription, codes for TAT protein which promotes viral transcription. Copyright REV gene, codes for the REV protein, which regulates translocation of unspliced and incompletely spliced RNAs. Poly is a really important person. The proteins coded by the pol gene are reverse transcriptase, integrase, and protease. Routes of transmission. Scent sexual, responsible for 80% of infections worldwide. 1 risk per sexual act equals risk for men who have sex with men. MSM 0.5% for receptive partner equals risk for male to female sex equals 0.1% for female partner equals 0.05% for male partner. Modifying factors. Viral load. Studies have shown that transmission is unlikely if viral load is scent. Vertical transmission, from mother to child. Copyright during childbirth, 5 to 15%. C4 copyright through breastfeeding after birth, 5 to 20%. 7. BNB risk of transmission can be lowered significantly if HIV infection is treated consistently and viral load is below the limit of detection. References: 8IL2I91. OLO. Pathophysiology. Natural history of HIV infection. Scent initial infection and HIV replication cycle 1. HIV enters the body, example via mucosal lesions or via infection of mucosal/cutaneous immune cells, then attaches to the CD4 receptor on host cells with its GP120 glycoprotein, binding, equals cells that have CD4 receptors, T lymphocytes, example T helper cells, macrophages, monocytes, dendritic cells. 2. Viral envelope fuses with host cell, capsid enters the cell. Equals 4. Fusion, CD4 receptor and a coreceptor, CCR5 in macrophages, and CCR5 or CXCR4 in T cells, must be present. Viral entry into macrophages via CCR5 mainly occurs during the early stages of infection, while entry via CXCR4 occurs in later stages. Individuals without CCR5 receptors appear to be resistant to HIV. Those patients either have a homozygous CCR5 mutation, substantial resistance, or a heterozygous CCR5 mutation, slower course. 3. A virion's RNA is transcribed into dsDNA by viral reverse transcriptase and then integrated into the host's DNA by viral integrase. 4. Viral DNA is replicated and virions are assembled. 5. Virion repurposes a portion of the cell's membrane as an envelope and leaves the cell, budding, cell death. Fa0 progression to chronic immunodeficiency. Degree HIV infects CD4 lymphocytes, then reproduces and spreads to other CD4 lymphocytes near the original site of infection. Infection of CD4 lymphocytes concentrated in specialized lymphoid tissue, example lymph nodes or gut-associated lymphatic tissue, GALT. 1. Explosive growth and dissemination. Acute HIV syndrome with high viral load equals window period, the time between infection and detectability of HIV antibodies. Degree after the acute stage, viral load decreases, and remains at roughly that level for approximately 8 to 10 years, clinical latency stage. During the clinical latency phase, the virus mainly replicates inside the lymph nodes. Increasing loss of CD4 lymphocytes impairs immune function and, thereby, facilitates opportunistic infections and development of malignancies, AIDS. These secondary diseases are usually the cause of death in individuals with HIV. Back collapse. Fine text outline. Degree. Increased viral load generally leads to a decreased number of CD4 lymphocytes and vice versa, but the relation is not linear. Copyright viral load predicts the rate of disease progression and CD4 count correlates with immune function. Copyright acute HIV syndrome does not develop in all patients. Absence of symptoms may delay diagnosis. The role of immune response. Sent because HIV infects cells of the immune system itself, activation of cellular immunity is a factor that paradoxically helps the virus spread and ensures chronic persistence of the infection. Sent HIV evades immune control via copyright genetic mutation and recombination, copyright downregulation of MHC class surface molecules in infected cells. References: 8LL2I11. OE. Clinical features. General considerations. There are no clinical features specific to HIV infection. Sent in early HIV infection, patients are often asymptomatic. F2E incubation period, usually 2 to 4 weeks plus infectiousness, 2 peaks, 1 degree * peak, within the first months after infection, 2-4 peak, during AIDS stage, 1. Acute HIV infection, 131I8. Also referred to as acute retroviral syndrome, ARS, or described as a mononucleosis-like syndrome, O fever, fatigue, myalgia and arthralgia, headache. Degree generalized non-tender lymphadenopathy - generalized rash, gastrointestinal symptoms, nausea, diarrhea, weight loss, oropharyngeal symptoms, sore throat, ulcerations, painful swallowing, clinical latency and AIDS. Degree. Sent clinical latency, infected individuals may still be asymptomatic. Non-AIDS defining conditions, common when CD4+ count is below 500 cells/mm, copyright chronic subfebrile temperatures O persistent generalized lymphadenopathy, copyright chronic diarrhea, 1 month, copyright localized opportunistic infections equals oral candidiasis, creamy, white patches on the mucous membranes of the mouth that can be scraped off, vaginal infections, example yeast, trichomonads, copyright oral hairy leukoplakia, lesions that cannot be scraped off located mainly on the lateral borders of the tongue, triggered by Epstein-Barr virus O HPV-related, squamous cell carcinoma of the anus, common in men who have sex with men, or cervix, copyright skin manifestations, e.g. molluscum contagiosum, warts, exacerbations of psoriasis, shingles, AIDS, see HIV-associated conditions. Test patients with a history of intravenous drug use who present with otherwise unexplained weight loss, depression, and/or dementia for HIV. Unlike oral candidiasis, esophageal candidiasis is an AIDS-defining condition. References: 8IL121I13. Back collapse, find text outline. Stages. CDC classification system for HIV sent, 41. CDC categories of HIV are based on CD4 count in combination with current or previously diagnosed HIV-related conditions. Sent any patient belonging in categories A3, B3, or C1, C3 is considered to have AIDS. Clinical category: a clinical category B CD4 cell count category. Clinical category C, normal cell count, 500-1500 cells/mm. Asymptomatic, acute HIV symptomatic conditions, AIDS defining conditions, or PGL not our C, 1, 2 500 cells/mm. AL by C1, 2, 200 to 499 cells/mm. A 2B2C2, 3. PGL equals persistent generalized lymphadenopathy WHO, World Health Organization, classification, 5. WHO classifies individuals with confirmed HIV infection according to clinical features and diagnostic findings, primary HIV infection, acute retroviral syndrome or asymptomatic clinical stage 1, persistent generalized lymphadenopathy, PGL, or asymptomatic clinical stage 2, example unexplained moderate weight loss. 10%, unexplained chronic diarrhea, 1 month, unexplained persistent fever, equals 37.6 degrees Celsius intermittent or constant 1 month, persistent/severe fungal/viral/bacterial infections, unexplained anemia. WA. As diagnostics. Overview of tests and methods, 161. Serological assays. Serological assays are commonly used for both screening and diagnosis and may detect HIV antigen, antibodies, or both. Scent HIV antigen alone detects HIV P24 antigen. HIV antibody assays, i.e., third generation and below, detect IgM and IgG antibodies. O laboratory methods enzyme-linked immunosorbent assays, ELISA, equals HIV-1 and HIV-2 antibody differentiation immunoassay laboratory-based test that can differentiate between HIV-1 and HIV-2, provides separate results for each analyte, equals most commonly used confirmatory test in the US equals Western blot, detects only IgG antibody to HIV-1 plus combination HIV antibody with HIV antigen test, i.e., fourth generation and above can detect HIV IgG and IgM antibodies and P24 antigen. 211,122. See ISIN of HIV assays, 161. I21 generation test characteristics detects IgG only, cannot differentiate between HIV-1 and HIV-2 infection, sensitive but not very specific. First generation HIV test. Second generation HIV test. Detects IgG and IgM, cannot differentiate between HIV-1 and HIV-2 infection, more sensitive and specific. Third generation HIV test. Detect both HIV antigen, P24 capsid protein, and anti-HIV antibodies, IgG and IgM antibodies against HIV-1/HIV-2, cannot differentiate between HIV-1 and HIV-2 infection, improved sensitivity in early/acute infection. Fourth generation HIV test. Detect both HIV antigen, P24 capsid protein, and anti-HIV antibodies, IgG and IgM antibodies against HIV-1/HIV-2, includes HIV-1 and HIV-2 antibody differentiation immunoassay, can differentiate between HIV-1 and HIV-2. 21. Fifth generation HIV test. 21. Very sensitive and specific, may not require confirmatory testing. Virological testing. 231. Virological tests are most commonly used for screening infants and confirmation of disease in both infants and adults. Scent can detect HIV-1 RNA and/or DNA, depending on the test. Scent laboratory method, nucleic acid testing, NAT, screening and diagnosis. Back collapse, fine text outline. Screening and diagnosis. Our peers Y-based HIV study 24-23 age preferred test adults and children equals 18 months. Scent fourth generation HIV test, IgN/antibody Y, screening infants. Scent HIV-1/2 antibody differentiation immunoassay adults and children 24 months plus HIV-1 NAT confirmation infants. Indications for HIV testing, 181L19. HIV testing should be offered to patients who have signs that raise concern for HIV infection, prior exposure, and as part of routine screening. Routine screening. Copyright all individuals equals 13 years of age in all healthcare settings. 1251L19. Copyright any individuals, even if previously tested equals starting treatment for tuberculosis, attending STI clinics or diagnosed with an STI. Copyright one-time testing is recommended early in all pregnancies. Scent targeted testing. Copyright all patients with clinical features of acute or chronic HIV infection or opportunistic infections. Copyright all individuals with possible past exposure, especially individuals at High risk of HIV infection, example sex workers, men who have sex with men, individuals who use 4 drugs, partners of HIV-positive individuals. Copyright annual screening for individuals at high risk of HIV infection. In most U.S. states, HIV testing requires patient consent. Opt-out. In the majority of locations, oral consent is sufficient, but check local guidance. Screening studies 241. Scent HIV serology copyright 4th generation HIV test, combination HIV antibody with HIV antigen, 21 timing, detectable 14 days after transmission 21 equals not recommended for suspected neonatal HIV infection, results may be false positive because of maternally transferred anti-HIV antibodies, 23 copyright 3rd generation HIV test, antibody only frequently used in rapid tests, point of care tests, 1 cent virological tests copyright HIV-1 NAT, used for screening in infants aged. Copyright a negative combination antibody/antigen test 2 weeks after exposure essentially rules out HIV infection, almost 100% sensitivity. Confirmatory studies. Scent serology copyright HIV-1 and HIV-2 antibody differentiation immunoassay 21. Equals timing, detectable 3 weeks after infection 21 equals positive result, HIV infection confirmed equals negative or indeterminate result, perform HIV-1 NAAT. Positive HIV-1 NAT, HIV-1 infection confirmed equals negative HIV-1 NAT, antibody test was likely a false positive HIV-1 Western blot, the CDC no longer recommends Western blot tests for confirmation of HIV infection. 1. 241 cent virological tests HIV-1 NAT 7124, equals timing, can measure the amount of viral RNA in the blood and detect HIV infection earlier than antibody/antigen-based tests, 10 days after transmission. Equals indications neonatal HIV infection equals patients with indeterminate results 1. 2627 equals patients presenting before seroconversion screening of blood donors 128 equals disease monitoring 29. Back collapse fine text outline. Additional evaluation for patients with newly diagnosed HIV BOS Y. Advanced HIV studies. The following studies are recommended to screen for drug resistance, assist in the selection of an appropriate ART regimen, and establish a baseline to monitor the efficacy of therapy. Plus HIV drug resistance testing, genotypic assays are preferred over phenotypic assays. $32 IL-30 plus CD4 plus count, correlates with overall immune function 81 copyright normal values are 500 cells/mm registered, whereas in the advanced stages of HIV the CD4 plus count is often 1 destruction of CD4 plus lymphocytes more severe immunodeficiency worse prognosis, 33. Scent CD4 cell percentage, used for the assessment of immune function and less variable than CD4 plus count 31. Scent CD4-CD8 ratios, no longer routinely recommended. An increase in the ratio following ART initiation suggests improved immune system functioning. Measurement of CD8 cell count and CD4-CD8 ratios is not routinely recommended, as the results are not used to guide treatment. 31. WACE. Management. General Principles 201,341. Copyright all individuals with HIV infection, regardless of CD4 count, should begin antiretroviral therapy, ART, as soon as possible, antiretroviral drugs are combined to prevent resistance. All antiretroviral drugs are able to target both HIV-1 and HIV-2, except for enfuvirtide and NNRTIs. Copyright tailor therapy to the HIV genotype, if needed. Establish regular monitoring to assess treatment response. Degree if CD4 count is Copyright adherence to art can be improved by considering social determinants of health and addressing modifiable factors such as comorbid mental illness or substance use disorder, unstable housing, and barriers to attending regular clinic visits. 30. Copyright in the U.S., HIV/AIDS is a notifiable disease in every state. WAOE. ES antiretroviral therapy. Copyright initiation of art should be delayed in the setting of TB meningitis and cryptococcal meningitis because of the high risk of immune reconstitution syndrome. Initial art regimens 3 degrees. Asterisk preferred art regimens should consist of one of the following combinations: O2 NRTIs plus 1 RUTI O2. NRTIs plus 1 pi, boosted, O2 NRTIs plus 1 ENI copyright 1 NRTI plus 1 ENI 4. Stopping NRTIs in patients with hepatitis B co-infection can lead to an acute worsening of their hepatitis. Overview of antiretroviral drugs /0LL371I38. Nucleoside reverse transcriptase inhibitors, NRTIs. Scent medications in class. Nucleoside reverse transcriptase inhibitors, NRTIs. Scent medications in class copyright abacavir, ABC, copyright didenosine, DDL, O-emtricitabine, FTC, olamivudine, 3TC, ostavudine, D4T, copyright tenofovir, nucleotide analog, also called nucleotide reverse transcriptase inhibitor, NTRTI, equals tenofovir disoproxil, TDF, equals tenofovir alafenamide, TAF, copyright zidovudine, ZDV, formerly AZT, scent mechanism of action ONRTIs act as nucleoside analogues competitive blockage of nucleoside binding to reverse transcriptase inhibition of formation of 3 to 5. Phosphodiester linkages termination of DNA chain equals inhibition of RNA to DNA reverse transcription degree activation requires intracellular phosphorylation, thus, NRTI efficacy is reliant on kinase availability and activity, which varies depending on cell functionality and activation state. 57. Copyright resistance is caused by mutations in the gene that codes for reverse transcriptase, POL gene, 39. Plus general adverse effects, 401L41 copyright mitochondrial toxicity 42. Equals a disruption of mitochondrial function most commonly caused by HIV treatment with nucleoside reverse transcriptase inhibitors equals NRTIs inhibit the enzyme responsible for the replication of mitochondrial DNA. Equals symptoms include, equals myopathy equals peripheral neuropathy equals hepatic steatosis equals lactic acidosis OHIV associated lipodystrophy, Cushing syndrome-like appearance abnormal distribution of fat 431L441L45. Equals loss of subcutaneous fatty tissue, lipoatrophy, in the face, extremities, and buttocks probable accumulation of fat in liver, muscles, abdomen, breasts, neck, double chin, and upper back, enlarged dorso-cervical fat pad, equals metabolic changes, impaired glucose tolerance, hyperlipoproteinemia, elevated triglycerides, elevated total cholesterol, lowered HDL, plus additional medication-specific adverse effects, 401L41 SAH Meshire web search O abacavir hypersensitivity reaction 46. 40 equals potentially life-threatening systemic reaction consisting of fever, rash, constitutional symptoms, vomiting, diarrhea, and, occasionally, respiratory distress. Avoid abacavir in HLAB*5701 positive patients. G. Pancreatitis, didenosine, stavudine cardiovascular disease, abacavir nephrotoxicity, tenofovir. Degree osteoporosis, tenofovir for bone marrow suppression causing anemia and neutropenia, zidovudine melanonychia, zidovudine Ha degree DNA depleting mitochondrial myopathy with red ragged fiber appearance, zidovudine 47. Most NRTIs end in INE, protease inhibitors in NAVER, and integrase inhibitors in GRAVER. The nuclear plant is in the VUDs, read, woods, nucleoside reverse transcriptase inhibitors end in VUDine. Non-nucleoside reverse transcriptase inhibitors, NNRTIs. Scent medications in class copyright Delaverdin copyright Doravirine o Favirenz copyright Adavirine o Nevirapine copyright Rilpivirine scent mechanism of action EO non-competitive inhibitors of viral reverse transcriptase that bind to the reverse transcriptase at a different location than NRTIs. NNRTIs do not require intracellular phosphorylation for activation because they are direct inhibitors. Plus general adverse effects /40 LL41. O hypersensitivity reactions, rash J.O. Stevens-Johnson syndrome. Back collapse fine text outline. Scent general adverse effects degree. O hypersensitivity reactions, rash A.O. Stevens-Johnson syndrome copyright toxic epidermal necrolysis Sarges Meshire web search. Asterisk additional medication specific adverse effects /401 L41. O hepatotoxicity equals Favirenz equals Nevirapine. Copyright CNS toxicity and vivid or disturbing dreams, Favirenz. HIV protease inhibitors, PLS. Scent medications in class. Degree atozanavir darunavir fosamprenavir lopinavir indinavir nelfinavir ritonavir sequinavir. Degree mechanism of action, inhibition of viral HIV-1 protease, encoded by pol gene, equals inability to cleave viral polyproteins into functional units generation of impaired viral proteins production of immature, non-infectious, virions, 48, plus general adverse effects /40 LL41 OGL upset, nausea, vomiting, diarrhea, nephrolithiasis, crystal-induced nephropathy, and hematuria 49-degree metabolic abnormalities. Equals hyperglycemia, inhibition of insulin-dependent glucose transporters, GLUT4, peripheral insulin resistance impaired glucose tolerance 50 equals dyslipidemia lipodystrophy and fat accumulation. Copyright increased risk of bleeding in patients with hemophilia 51 copyright changes to hair, example thinning. Additional medication-specific adverse effects, thrombocytopenia with indinavir, rare, 52 cent additional medication-specific information, boosted P monotherapy, example ritonavir combined with a second protease inhibitor, optimizes ART, i.e., preventing resistance, allowing less frequent dosing, limiting NRTI-related toxicity, 53. At subtherapeutic doses of ritonavir, boosting agent, can be used to increase concentrations of other HIV drugs because it is a cytochrome P450 inhibitor. 54. Integrase inhibitors, INAS or INSTIs. Scent medications in class copyright Bictegravir copyright Cabotegravir copyright Dolutegravir o Elvitegravir o Raltegravir mechanism of action, inhibition of the viral integrase blockade of viral DNA integration into the host's DNA equals inhibition of viral replication 37 plus general adverse effects 42-41 O rash O hypersensitivity syndrome in rare cases. Additional medication-specific adverse effects, muscle inflammation causing elevated creatinine kinase, Raltegravir, Dolutegravir 40-41. Entry inhibitors 55. Scent description, heterogenic class of antiretroviral drugs that inhibit binding or fusion of HIV virions with human cells. Infuvertide, fusion inhibitor. Mechanism of action, competitively binds to the viral protein GP41, thus preventing fusion with the cell 37O adverse effects, skin irritation at the site of drug injection *Mariviroc, CCR5 antagonist used in infection with drug-resistant HIV-1 scent. Degree mechanism of action, blocks the CCR5 core receptor on T cells and monocytes that is essential to cell infection for some HIV genotypes, R5 HIV-1, inhibition of GP120 interaction, prevention of virus docking. 871 O adverse effects, equals cough, upper respiratory tract infections. Back collapse, fine text outline. O adverse effects, equals cough, upper respiratory tract infections equals fever equals hepatotoxicity. And infuvertide provides diffusion of viral fusion. And Mariviroc will block the viral dock. And Psi preventative healthcare. Opportunistic infections 58L59. Scent patients with low CD4 counts are at increased risk of opportunistic infections. Scent see HIV-associated conditions for further information on prevention and management. Immunizations, 259ths. In addition to routine vaccinations, the following vaccines should be prioritized in this population: O. Hepatitis A vaccine, copyright hepatitis B vaccine, EO human papillomavirus vaccine, influenza vaccine, annually, O. meningococcal vaccine, i.e. O. pneumococcal vaccine, O. herpes zoster vaccine, E. COVID vaccine. Scent C immunizations in individuals with HIV. Copyright some live vaccinations, example the MMR, should not be given until CD4 count is equals 200, consult with an infectious disease specialist before giving vaccinations to patients with low CD4 counts. 59. Malignancy. Risk reduction. Scent early diagnosis and treatment of HIV with ART is the most important step in preventing HIV-associated malignancies. Scent treat co-infections, example HPV and HCV. Ensure patients receive vaccinations for oncogenic viruses, example HPV, hepatitis B. Encourage behavioral modifications. Copyright avoid needle sharing. EO smoking cessation. O maintain a normal BMI. Screening 6 degrees. Scent age-appropriate cancer screening, dash. Follow modified screening for HPV-associated cancers. Copyright cervical cancer screening, perform annual pap smears. OA copyright anal cancer screening, consider annual anoscopy and / anal cytologic screening dash. HPV co-testing at the time of a pap smear is not recommended for patients. WA. OE. Complications. Back collapse, fine text outline. Complications. Patients who start ART are at risk of developing complications related to the recovery of their immune system. Complications relating to immunocompromise, especially if CD4 levels are. Immune reconstitution, inflammatory syndrome, IRIS, 611621. Definition: an inflammatory syndrome that can occur after initiation of ART and consists of either the appearance of a new condition or worsening of a pre-existing condition. Epidemiology: common, occurs in 15 to 25% of patients starting ART. 63. Etiology: believed to result from the restoration of the immune system and its response to antigenic stimulation. The stimulus may be, 61. Copyright infectious, example Mycobacteria, HSV, CMV, Cryptococcus E. Autoimmune, example sarcoidosis, rheumatoid arthritis, SLE. Copyright malignant, example non-Hodgkin lymphoma. Clinical presentation 621. Copyright develops within 4 to 8 weeks of initiation of ART. O presentation varies depending on the underlying illness, however, patients often have clinical deterioration and localized tissue inflammation. Diagnosis is clinical * management. 2. Degree provide supportive care and continue treatment of the associated condition, example with antibiotics, chemotherapy. Copyright do not interrupt ART except in severe, life-threatening IRIS. Copyright consider corticosteroids, example prednisone, for severe IRIS depending on the underlying cause. Prevention. Copyright initiation of ART, start within 2 weeks or as soon as clinically stable in patients being treated for opportunistic infections, except in tuberculous meningitis, cryptococcal disease, and CMV retinitis. A copyright corticosteroids should not be used to prevent the development of iris. Registered corticosteroids should not be given to prevent iris, nor should they be used to manage iris caused by Kaposi sarcoma or cryptococcal meningitis. 62. We list the most important complications. The selection is not exhaustive. Prognosis. Morbidity and mortality among patient subsets. Untreated, HIV leads to death on average 8 to 10 years after infection. Copyright progression varies among individuals. Some patients may die within a few years while others can remain asymptomatic for decades. Untreated individuals with advanced HIV infection usually die within a few years. Median survival is 12 to 18 months. Some untreated individuals show only slow progression and can remain asymptomatic for more than 20 years. In rare cases, untreated individuals have no detectable viremia and continue to have high CD4 counts for long periods. The average life expectancy of HIV-infected individuals who receive adequate antiretroviral treatment is approaching that of non-infected individuals of the same age. 65-66. Copyright individuals with HIV infection on adequate antiretroviral therapy are more likely to develop chronic comorbidities, example cardiovascular disease, diabetes, cancer, than healthy individuals. 671 LE8. Individual prognosis depends on various factors, including adequate antiretroviral treatment, viral setpoint and CD4 count. Copyright exposure to opportunistic pathogens, copyright individual genetic properties, copyright HIV species and subtype, copyright pre-existing conditions. OFU. Prevention. Risk reduction 691. Back collapse. Fine text outline. Prevention. Risk reduction 69. All patients should be counseled on the following risk reduction measures. Barrier contraception. Avoiding shared for-drug equipment. Regular HIV and STI screenings, including in all new sexual partners. HIV pre-exposure prophylaxis, PrEP, 7 degree. Definition. The use of art to prevent infection in individuals at high risk of contracting HIV. Eligibility. Negative HIV test result and no signs or symptoms of acute HIV infection. Normal renal function test. Copyright fulfillment of at least one indication criterion. Indications for HIV PrEP. Men who have sex with men equals any anal sex without condoms in the past 6 months. Of bacterial STI, example syphilis, chlamydia, or gonorrhea, diagnosed or reported in the past 6 months. Heterosexual men and women equals sexually active with an HIV-positive partner equals inconsistent or no condom use during sexual activity with one or more sexual partners of unknown HIV status equals a bacterial STI in the past 6 months. Copyright individuals who inject drugs with high-risk needle behavior, example sharing needles or equipment, or with an HIV-positive injection partner. Timing. Prior to the exposure to HIV and continued for a month after the exposure. 171 regimens. Copyright preferred regimen, emtricitabine plus tenofovir disoproxil fumarate, may be given as a single tablet of Truvada registered. Copyright alternative, not for patients at risk via receptive vaginal sex. Emtricitabine plus tenofovir alafenamide, may be given as a single tablet of Descovy registered. 72, 73 follow-up. Every 3 months equals testing, HIV screen, STI screening, pregnancy test if indicated equals assessment and counseling, medication adherence, side effects, risk behaviors. Every 6 months, check renal function. Every 12 months, assess the need for continuing HIV PrEP. HIV post-exposure prophylaxis, PEP, 741. Definition, a short course of art taken by patients after a potential exposure to HIV. Indications for HIV PEP, Copyright injury with HIV-contaminated instruments or needles. Copyright contamination of open wounds or mucous membranes with HIV-contaminated fluids. Unprotected sexual activity with a known or potentially HIV-infected person. Scent timing, initiate as soon as possible, ideally within 1 to 2 hours of exposure. Scent drugs, a 3-drug regimen is recommended, similar to ART. Typically, this includes a nucleoside/nucleotide combination NRTI plus an integrase inhibitor, e.g. 7. Copyright tenofovir disoproxil fumarate plus emtricitabine, may be given as a single combined tablet of Truvada registered, O plus one of the following, equals dolutegravir equals raltegravir. Scent further management. E for occupational exposure, follow the procedure for healthcare personnel exposures, see infection prevention and control. Counsel patients to use barrier contraception, avoid donation of blood, semen, or tissue, and, if possible, avoid pregnancy and breastfeeding throughout the 6-month follow-up period. Ensure patients are educated about the adverse effects of medications and that they have appointments booked for testing, see follow-up for exposure to blood-borne viruses. Special patient groups. HIV in pregnancy. Scent transmission. Copyright highest risk during birth, perinatal vertical transmission, copyright prenatal transmission is possible. The risk depends on maternal viral load. Antepartum and intrapartum management. Back collapse. Find text outline. X. Human immunodeficiency virus infection. Scent timing, initiate as soon as possible, ideally within 1 to 2 hours of exposure. Scent drugs, a 3-drug regimen is recommended, similar to ART. Typically, this includes a nucleoside/nucleotide combination NRTI plus an integrase inhibitor, e.g. CA. 7. Copyright tenofovir disoproxil fumarate plus emtricitabine, may be given as a single combined tablet of Truvada registered, O plus one of the following, equals dolutegravir equals raltegravir. Scent further management. O for occupational exposure, follow the procedure for healthcare personnel exposures, see infection prevention and control. Counsel patients to use barrier contraception, avoid donation of blood, semen, or tissue, and, if possible, avoid pregnancy and breastfeeding throughout the 6-month follow-up period. Ensure patients are educated about the adverse effects of medications and that they have appointments booked for testing, see follow-up for exposure to blood-borne viruses. Special patient groups. HIV in pregnancy. Scent transmission. Copyright highest risk during birth, perinatal vertical transmission, prenatal transmission is possible. The risk depends on maternal viral load. Scent antepartum and intrapartum management. Combined antiretroviral therapy, CART, is recommended throughout pregnancy and delivery. 1. Copyright. The mode of delivery and the use of additional 4-zidovudine depend on the maternal viral load during the intrapartum period, both of which must be considered to reduce the risk of transmission of HIV to the infant. Copyright. Zidovudine is also one of the few antiretroviral medications approved for HIV post-exposure prophylaxis in neonates. Nevirapine. Copyright or 3-drug regimen, zidovudine, lamivudine, and either nevirapine or intrapartum management of HIV 75I76. Maternal heat time of delivery method. Intrapartum antiretroviral treatment. Infant prophylaxis. Increased risk of HIV transmission. Scent administer 4-zidovudine 3 hours. Administer CART for 6 weeks. NEN and Lees Sp. Cesarean delivery should be scheduled at 38 weeks before cesarean delivery. 2D, Idavudi 4323, Ooperia etoicted 2, even if the patient received CART during pregnancy. Administer 4-zidovudine immediately. Westus, SAEE if the patient presents in labor. 4-zidovudine is administered based 50s 1000 copies/mlirc3 please. On an individualized decision. 4. fall to grave or low risk of HIV transmission. Vaginal delivery. New York 4 zidovudine is not recommended. SS. Scent postpartum management. O. Post-exposure prophylaxis in neonates, see infant prophylaxis in the table above. O. Breastfeeding should generally be avoided in countries with good food availability and hygienic baby food, example clean drinking water, because risk of transmission is 5 to 20%. 1. OC perinatally acquired HIV. Plus diagnosis in infants, if copyright suspect HIV in infants with failure to thrive, diffuse lymphadenopathy, diarrhea, and thrush, especially if the mother is a high-risk patient. WI. CE. Related 1-minute telegram. Sent 1-minute telegram 86-2023-2/3, DEX does not pass the test in patients with TB, meningitis and HIV. Sent 1-minute telegram 82-2023-1/3, protect with PrEP. Sent 1-minute telegram 80-2023-1/3, pitavastatin to prevent CVD in HIV. Interested in the newest medical research, distilled to just 1 minute? Sign up for the 1-minute telegram in the tips and links below. Back collapse. Fine text outline. Human immunodeficiency virus infection, 1/1. HIV infection/AIDS. Epidemiology incidence, US, 38,000, worldwide 1.7 million, 2018, peak incidence between ages 20 and 30. AIDS peak incidence approximate age 45. Prevalence, US, 1.1 million, worldwide 38 million, 2018. Etiology: human immunodeficiency virus transmission, sexual, parenteral, vertical. Clinical stages: acute infection, fever, fatigue, lymphadenopathy. Latent period, asymptomatic or non-AIDS defining conditions. AIDS defining conditions. Diagnosis: screening test, e.g. combination antigen/antibody immunoassay, confirmatory test, e.g. antibody differentiation immunoassay. Complications include wasting syndrome, HIV encephalopathy, HIV-associated risk of cardiovascular disease, opportunistic infections, malignancies. HIV/AIDS fact sheet. Copyright Boss. Acute infection, 1 to 2 weeks, fever, or increased temperature, lymphadenopathy, diarrhea. Latency, months to decades. 3. Oral ulcers. Exanthem of. Oral hairy leukoplakia, dysplasia, oral candidiasis, opportunistic infection. The trunk. Arthralgia. B symptoms: fatigue, headache, loss of appetite. Herpes zoster, opportunistic infection. Cytopenia and bone marrow suppression. Defining conditions, most common manifestations. F. Cerebral WIE1 toxoplasmosis HH. Pneumocystis, 6 pneumonia. /+_esophagitis. Kaposi sarcoma. Loss of 10% body weight within 6 months. Greater than 30 days of diarrhea, fever, and weakness. HIV infection: human immunodeficiency virus, HIV1/HIV2, OE, sexual, vertical, parenteral transmission. Usually 2 to 4 weeks, but as long as 10 months, and incubation period has been observed. Acute, flu-like symptoms, lymphadenopathy, latent, asymptomatic or non-AIDS defining clinical features. Conditions: AIDS. SASN 38 million worldwide, 1.2 million US, 2018, prevalence. E 1.7 million worldwide, 2019, annual incidence. equals 690,000 worldwide, 2019, annual deaths. Education, safer sex practices etc., pre-exposure prophylaxis, PrEP, prevention and post-exposure prophylaxis, PEP, treatment, antiretroviral treatment for infected individuals, risk groups in the U.S., 2018 HIV prevalence, 15 to 49 years of age, E at MSM, 69% of new diagnoses, KS, EE injecting drug users, 7% of new diagnoses, F very high, 10%, nationally notifiable disease, US, BBTN, 3%-10%. IL intermediate, 1%-3%. Low, 0.1%-1%. Very low. HIV fact sheet and prevalence map VV. Copyright Boss. Map is based on data from the Joint United Nations Programme on HIV/AIDS, on AIDS, 2010 to 2015. Euro human immunodeficiency virus infection, 2/3. HIV infection human immunodeficiency virus, HIV1/HIV2, OOFPOOTT, sexual, vertical, parenteral transmission PG, usually 2 to 4 weeks, but as long as 10 months incubation period has been observed PE. Equals, acute, flu-like symptoms, lymphadenopathy, latent, asymptomatic or non-AIDS defining FEN clinical features conditions X, AIDS. SACM 38 million worldwide, 1.2 million US, 2018, prevalence. WHL 1.7 million worldwide, 2019, annual incidence. 690,000 worldwide, 2019, /annual deaths, education, safer sex practices etc., pre-exposure prophylaxis, PrEP, prevention and post-exposure prophylaxis, PEP, treatment, antiretroviral treatment for infected individuals. Risk groups in the U.S., 2018 annual HIV incidence, per 10,000, GYH at MSM, 69% of new diagnoses, of YAS injecting drug users, 7% of new diagnoses. Very high, 50. Very low. HIV fact sheet and incidence map. Copyright Boss. U.S. epidemiological figures based on data from the CDC, https://www.cdc.gov/hiv/statistics/overview/index.html. All other epidemiological figures based on data from the WHO, https://www.who.in/data. HIV infection human immunodeficiency virus, HIV1/HIV2. Asexual, vertical, parenteral transmission. Usually 2 to 4 weeks, but as long as 10 months incubation period has been observed. Acute, flu-like symptoms, lymphadenopathy, latent, asymptomatic or non-AIDS defining conditions, AIDS on 38 million worldwide, 1.2 million US, 2018, prevalence. DHL 1.7 million worldwide, 2019, annual incidence. 690,000 worldwide, 2019, X annual deaths. Education, safer sex practices etc., plus, pre-exposure prophylaxis, PrEP, prevention and post-exposure prophylaxis, PEP, Ustivant, antiretroviral treatment for infected individuals. Risk groups in the U.S., 2018 annual HIV-related deaths PT at MSM, 69% of new diagnoses, Y-feed injecting drug users, 7% of new diagnoses, very high, 50,000, nationally notifiable disease, U.S., high, 5,000 to 49,999. Intermediate, 500 to 4999, Biao, 100 to 499. I'm very low. HIV fact sheet and mortality map VV. Copyright Boss. U.S. epidemiological figures based on data from the CDC, https://www.cdc.gov/hiv/statistics/overview/index.html. All other. Epidemiological figures based on data from the WHO, https://www.who.in/data. Euro-human immunodeficiency virus infection, 1/3. CD4 plus or CD8 plus HIV RNA cells/mm. Copies/ml plasma. Equals plus 107. 04 had. 004 ns let //nn is N105.7 HIV RNA. J plus 10 degrees, 0, ideation 2 to 10 2 to 3. Natural course of HIV infection VV. Graph showing typical cell counts, antibody levels, and viral loads during different stages of untreated HIV infection/AIDS. The dashed line at the level of 500 cells/mm hashtag represents a state of moderate immunocompromise. CD4 asterisk or CD8 asterisk thresholds at which select common opportunistic infections most frequently occur. Attachment and penetration uncoating reverse integration transcription translation release transcription. 8 NEEAE CCR5YIJ antagonist. Anti-RT is Bran O//. YY protease OK /O NES inhibitors. And A equals and integrase OSA inhibitors, 4 SANNRTIs. Fusion YYFA inhibitors equals E. CCR5 antagonist, anti-RT is, protease inhibitors, Mariviroc tenofovir, adofovir efavirenz, nevirapin loperamivir, ritonavir, leseeiog sure indinavir, nelfinavir fusion inhibitors, NRTIs, integrase inhibitors, abacavir, didenosine, emtricitabine, lamivudine, stavudine, zidovudine infuverted. HIV replication and mechanism of action of antiretroviral drugs. Raltegravir, dolutegravir. 1 attachment, the viral envelope glycoprotein GP120, CAP, binds to CD4 receptors, which are present on certain cells. The GP120 CD4 complex then binds to the host chemokine receptor 5, CCR5. CCR5 antagonists prevent viral attachment to the host cell. 2 penetration, viral binding to CCR5 causes a conformational change in the envelope GP411, stalk, which enables HIV to fuse with and release its capsid into the host cell. Fusion inhibitors competitively bind to GP41 and prevent viral fusion with the host cell. 3 uncoating of the viral capsid to release viral RNA. 4 reverse transcription, viral RNA is transcribed into viral DNA by viral reverse transcriptase enzymes. Nucleoside reverse transcriptase inhibitors, NRTI, nucleotide reverse transcriptase inhibitors, NTRTI, and non-nucleoside reverse transcriptase inhibitors, NRTI, inhibit the viral reverse transcriptase enzyme. Attachment and penetration uncoating reverse integration transcription translation release transcription. 1. ALET. CCR5 /VE antagonist. Anti-RT is N. NRT is VVN/**/*. YY protease waggle /*/O NES inhibitors. And A equals and integrase OSAN inhibitors, for many NNRTIs equals SS374, fusion YGFA inhibitors EZ equals. CCR5 antagonist, anti-RT protease inhibitors, marivirok tenofovir, atofovir efavirenz, nevirapin loperavir, ritonavir, leseeiog shore indinavir, nelfinavir fusion inhibitors, NRTIs, integrase inhibitors, infuverted abacavir, didenosine, emtricitabine, raltegravir, dolutegravir lamivudine, stavudine, zidovudine. HIV replication and mechanism of action of antiretroviral drugs VV. PEETTEQEE New York CEN NEM NEWE NE EEEEP were 5. Integration. Newly transcribed viral DNA is integrated into host DNA by viral integrase. Integrase inhibitors inhibit viral integrase. 6. Transcription. Newly integrated DNA is used as a template to create copies of viral RNA that will encode for viral proteins. 7. Translation. Newly transcripted viral RNA acts as templates for the synthesis of new viral protein synthesis. Viral protease enzyme cleaves the long polypeptide chains into shorter, functional viral proteins, example envelope proteins, enzyme proteins. Protease inhibitors inhibit viral protease and prevent the generation of functional viral proteins. 8. Release. New viral RNA and viral proteins use a portion of the host cell membrane as a viral envelope and then leave the host cell. Copyright Emboss. HIV-infected T-cell. Colorized scanning electron micrograph. The T-cell is red and the HIV virus yellow. Source, ID #18143, National Institute of Allergy and Infectious Diseases, NIAID, Centers for Disease Control and Prevention licensed under public domain. Human immunodeficiency virus infection, 1/4. Oral candidiasis VV. There is a distinct area of white plaque on the oral mucosa that can be scraped off. This finding is characteristic oropharyngeal candidiasis, oral thrush. Source, ID #6066, CDC/Sol Silverman, Jr., DDS, Centers for Disease Control and Prevention, CDC, licensed under public domain. Human immunodeficiency virus infection, 2/4. Oral candidiasis VV. Oral mucosa of an HIV-positive patient. There are several distinct white plagues on the soft palate and uvula. Source, ID #6053, CDC/Sol Silverman, Jr., DDS, Centers for Disease Control and Prevention, CDC, licensed under public domain. Human immunodeficiency virus infection, 3/4. HIV patient with oral hairy leukoplakia VV. A 3 to 5 cm confluent, white plaque with a hairy appearance is seen across the left lateral side of the tongue that, in this case, could not be scraped off using a spatula. This clinical finding is characteristic of oral hairy leukoplakia. Source, ID #6061, CDC/JS Greenspan, BDS, University of California, San Francisco, Sol Silverman, Jr., D.D.S., Centers for Disease Control and Prevention, CDC, licensed under public domain. Human immunodeficiency virus infection, 4/4. Shingles VV. A widespread erythematous papular rash is visible over the left inguinal region. Several individual and confluent vesicles can be seen in a 1T12L1 dermatomal distribution. Additional lesions are visible beyond this distribution. This is the characteristic appearance of shingles, herpes zoster infection. Source, copyright IMPP. Human immunodeficiency virus infection, 1/4. NRTI-associated lipodystrophy. A disturbed distribution of subcutaneous fat with a major loss of buccal and temporal fat results in the appearance of a sunken face while the dorso-cervical fat pad is greatly enlarged. These findings are characteristic of lipodystrophy and can be a side effect of antiretroviral therapy with nucleoside reverse transcriptase inhibitors such as stavudine or tenofovir. Source: Figure 85, an adult with stavudine-associated, in, Atlas of Pediatric HIV Infection by Regina E. Olodican, Raniko J. Leloania, Carol Hlila et al., Open Books, licensed under CC by ND 4.0. Human immunodeficiency virus infection, 2/4. Melanonychia 4. Both nails show narrow, darkened stripes caused by longitudinal hyperpigmentation. These findings are characteristic of melanonychia, which is the result of increased activation of melanocytes and is more prevalent among people with dark skin color. An extension of the stripes onto the cuticle and proximal nail folds, Hutchinson nail sign, is suggestive of subungual melanoma. Source: Figure 97b, Melanonychia by Regina E. Olodican, Raniko J. Leloania, Carol Hlila et al., Open Books, licensed under CC by ND 4.0. Human immunodeficiency virus infection, 3/4. Hair changes in HIV/VV. The hairline is high and thinned out, alopecia, and the remaining hair has a very fine texture. The cause of these alterations is usually multifactorial, resulting from, example antiretroviral therapy, example if treated with indinavir and ritonavir/lopinavir, nutritional deficiency and inflammatory disorders of the scalp. If drug-induced, the alopecia will generally reverse after substitution with a different drug. Diffuse alopecia is seen in approximate 7% of individuals with HIV. Source: Figure 96, Hair changes, in, Atlas of Pediatric HIV Infection by Regina E. Olodican, Raniko J. Leloania, Carol Hlila et al., Open Books, licensed under CC by ND 4.0. Human immunodeficiency virus infection, 4/4. Attachment and penetration uncoating reverse integration transcription translation release transcription. LROC. CCR5QYTE antagonist //WSAFJIOEE /P414 NTRT is NNE4 /EP120 cent Y equals ES, rho LF, IE, BNRT is an LE, Z equals HES/P24/AS underscore NG pi ROG ////J, inhibitors. Me2EE and integrase YAEEAEQ inhibitors /4EY MES NNRT is SS74. A fusion XYPFA inhibitors __. CCR5 antagonist, NTRT is, protease inhibitors, Mariviroc tenofovir, adifovir efavirenz, nevirapin loperamivir, ritonavir, fusion inhibitors, NRTIs, integrase inhibitors, indinavir nenanavir infuverted abacavir, didenosine, emtricitabine, raltegravir, dolutegravir lamivudine, stavudine, zidovudine. HIV replication and mechanism of action of antiretroviral drugs VV. 1. Attachment, the viral envelope glycoprotein GP120, CAP, binds to CD4 receptors, which are present on certain cells. The GP120 CD4 complex then binds to the host chemokine receptor 5, CCR5. CCR5 antagonists prevent viral attachment to the host cell. 2. Penetration, viral binding to CCR5 causes a conformational change in the envelope GP411, stalk, which enables HIV to fuse with and release its capsid into the host cell. Fusion inhibitors competitively bind to GP41 and prevent viral fusion with the host cell. 3. Uncoating of the viral capsid to release viral RNA. 4. Reverse transcription, viral RNA is transcribed into viral DNA by viral reverse transcriptase enzymes. Nucleoside reverse transcriptase inhibitors, NRTI, nucleotide reverse transcriptase inhibitors, anti-RTI, and non-nucleoside reverse transcriptase inhibitors, NRT, inhibit the viral reverse transcriptase enzyme. Euro-human immunodeficiency virus infection, 1/1. Immune reconstitution inflammatory syndrome, IRIS. Smooth and mostly dome-shaped papules with central umbilications are visible on the chin and chest of this child. Areas with high concentrations of papules, example chin, show an erythematous ground. These findings represent the paradoxical flare-up of infection with molluscum contagiosum during antiretroviral therapy, IRIS. Source, Figure 95, a flare-up of, in, Atlas of Pediatric HIV Infection by Regina E. Oladican, Raniko J. Leloania, Carol Hlila et al., Open Books, licensed under CC by ND 4.0. XXX neonatal conjunctivitis. Neonatal conjunctivitis is inflammation of the conjunctiva in infants. Income countries because of the implementation of comprehensive preventive measures, i.e., counseling on sexually transmitted infection prevention, antenatal screening and treatment of infections, and prophylactic antibiotics at birth. WA OE Overview. Etiology. Onset after birth. Clinical features. Diagnostics. Treatment. Prevention. Overview of conjunctivitis in newborns LOLs. Ivides, 2142. And gonorrhoea, highly contagious. Typically 2 to 5 days. Similar to gonococcal conjunctivitis in other age groups, profuse, purulent ocular discharge, pronounced eyelid swelling. Gram stain of conjunctival exudate 1 copyright increased WBC's copyright intracellular gram-negative diplococci culture of the conjunctiva, and gonorrhoea. 4 or IM third generation cephalosporin treat concurrent chlamydial infection if present. Provide treatment of gonorrhea to mothers and at-risk partners. Prenatal screening and treatment for maternal infection, routine antibiotic prophylaxis within 1 hour of birth with erythromycin ointment al. ERY4. Scent C. Trichomonas serotypes DK. Scent typically 5 to 14 days. Scent unilateral or bilateral scent purulent or mucopurulent ocular discharge, may be blood-stained. 5. Scent eyelid edema, scent bulbar conjunctival injection, scent concurrent infection of nasopharynx, genitals, or lungs. Scent direct fluorescent antibody test *PCR* culture of the conjunctiva 29. Scent oral erythromycin, scent treat concurrent gonococcal infection if present. Scent treat genitourinary chlamydia in mothers and at-risk partners. Scent prenatal screening and treatment for maternal infection. OE. Epidemiology. Neonatal HSV conjunctivitis, 2. HSV1 and HSV2. Usually up to 14 days 2. Non-purulent ocular discharge, corneal ulceration, periocular vesicles may exhibit other features of neonatal HSV infection, example meningoencephalitis. PCR viral cultures, direct fluorescent antibody test and enzyme immunoassay. For acyclovir, 2 specialists may consider adjunctive topical antivirals. See also neonatal HSV. Prenatal screening and treatment for maternal infection. Scent prevalent in resource-limited countries, significant cause of pediatric blindness in these countries. 8 Scent incidence in the U.S. is approximately, V7O chlamydial neonatal conjunctivitis, 2.1 per 100,000 live births. OE neonatal gonococcal conjunctivitis, 0.2 per 100,000 live births. Scent 30 to 50% of infants born to mothers with gonorrhea or chlamydia will develop neonatal conjunctivitis. 7. Epidemiological data refers to the U.S., unless otherwise specified. Back. Via collapse. A. Find text. Aseptic neonatal conjunctivitis. Usually due to silver nitrate exposure. Usually the first day. Mild conjunctival injection. Usually clear from patient history. Perform diagnostic studies for neonatal conjunctivitis to rule out infectious causes. Flush eye with saline. Avoidance of silver nitrate solution as prophylaxis for conjunctivitis. O. Outline. X. Neonatal conjunctivitis. Epidemiology. Scent prevalent in resource-limited countries, significant cause of pediatric blindness in these countries. 5 cent incidence in the U.S. is approximately, V7 copyright chlamydial neonatal conjunctivitis, 2.1 per 100,000 live births. Copyright neonatal gonococcal conjunctivitis, 0.2 per 100,000 live births. Plus 30 to 50% of infants born to mothers with gonorrhea or chlamydia will develop neonatal conjunctivitis. 7 epidemiological data refers to the U.S., unless otherwise specified. WA. CES. Etiology. Scent transmitted perinatally via exposure in utero or during vaginal delivery. 5 common pathogens include 2IL6, degree bacteria chlamydia trachomatis, most common, equals Neisseria gonorrhoeae Pseudomonas aeruginosa, common in premature infants, equals Streptococcus pneumoniae equals Haemophilus influenza. O viruses equals herpes simplex virus equals adenovirus. OFA, X. Clinical features. Plus develop within 2 to 28 days of birth, dependent on etiology. 1 common features include, 2. Copyright conjunctival injection. O chemosis. O eyelid edema. Copyright ocular discharge, may be watery, blood-stained, or purulent. 5. May be accompanied by systemic symptoms depending on the causative pathogen. Falcid. 4 OHSV, vesicular rash, meningoencephalitis, CHSV infection in the newborn, MSEO Pseudomonas, sepsis, meningitis. O and gonorrhoeae, sepsis, arthritis, meningitis, C disseminated gonococcal infection. At infants infected with C. trachomatis may present with pneumonia 3 weeks to 3 months after birth. This may be after conjunctivitis has resolved. 2. WA. CES. Complications. IS. Scent endophthalmitis. Scent corneal perforation. Scent blindness. Scent disseminated infection, meningitis, sepsis. We list the most important complications. The selection is not exhaustive. Back collapse. Find text outline. Equals neonatal conjunctivitis, 1/4. Infant with gonococcal ophthalmic disease. The eyelids are swollen, with purulent exudate forming crusts around them. Below the crusts there may be a large reservoir of pus. Special care should be taken and safety goggles should be worn when examining the eyes. Source, ID #3766, CDC/J Pledger, Centers for Disease Control and Prevention, CDC, licensed under public domain. Herpes simplex keratitis. Slit lamp photography with fluorescein stain and cobalt blue light filter. Dendritic lesions of the cornea appear green under cobalt blue illumination after fluorescein stain. These lesions are characteristic of keratitis caused by herpes simplex virus, HSV. Source, Dendritic corneal ulcer by Imran Kabir Hossain, Wikimedia Commons, licensed under CC by SA 4.0. Neonatal conjunctivitis, 3/4. Chlamydia trachomatis in McCoy cell culture VV. Photomicrograph of cells in McCoy cell culture, unknown magnification, cells infected with chlamydia trachomatis, black arrows, show inclusion bodies, reticulate bodies, here in brown, under the microscope. Chlamydia are obligate intracellular bacteria that require cell culture, rather than growth medium, to grow. This characteristic is especially important for determining the best antibiotic for treatment. Source: ID hashtag 6428, CDC/Drive Eram, Drive and Jacobs, Centers for Disease Control and Prevention, CDC, licensed under public domain. A neonatal conjunctivitis, 4/4. Overlay. Chlamydia trachomatis in McCoy cell culture, magnified view, VV. Photomicrograph of cells in McCoy cell culture, 200x magnification. The cells infected with Chlamydia trachomatis, example circled in blue, are identifiable by inclusion bodies, brown, example marked by hatched overlay, surrounded by a thin rim of host cytoplasm. Over the course of the pathogen's life cycle, elementary bodies, examples circled in white, are formed within the inclusion bodies. These are released from the cell and serve to transmit the pathogen to other cells or hosts. Source: ID hashtag 3802, CDC/Drive Eram, Drive and Jacobs, Centers for Disease Control and Prevention, CDC, licensed under public domain. A neonatal conjunctivitis, 4/4. NESS to GL. Overlay. Chlamydia trachomatis in McCoy cell culture, magnified view, VV. Photomicrograph of cells in McCoy cell culture, 200x magnification. The cells infected with Chlamydia trachomatis, example circled in blue, are identifiable by inclusion bodies, brown, example marked by hatched overlay, surrounded by a thin rim of host cytoplasm. Over the course of the pathogen's life cycle, elementary bodies, examples circled in white, are formed within the inclusion bodies. These are released from the cell and serve to transmit the pathogen to other cells or hosts. Source: ID hashtag 3802, CDC/Drive Eram, Drive and Jacobs, Centers for Disease Control and Prevention, CDC, licensed under public domain. Neonatal conjunctivitis, 1/2. Infant with gonococcal ophthalmic disease. The eyelids are swollen, with purulent exudate forming crusts around them. Below the crusts there may be a large reservoir of pus. Special care should be taken and safety goggles should be worn when examining the eyes. Source: ID hashtag 3766, CDC/J Pledger, Centers for Disease Control and Prevention, CDC, licensed under public domain. PCE, IAJ, IESAEGE5s of EEEEAE. Neonatal herpes simplex. Scalp of a 9-day-old newborn. Multiple partially confluent vesicles on an erythematous base are visible on the right frontotemporal aspect of the scalp. Further erythematous patches can be seen over the right temple and forehead. Source: Herpes neonatal herpes simplex by Kapitein Cavern, Wikimedia Commons, licensed under CC by SA 4.0. X fever in infants. Ever in infants. Strategy: risks iatrogenic harm from over-investigation and treatment. For management of fever in children and infants 60 days of age, see pediatric fever. OS. And epidemiology. Every year approximately 100,000 infants. OC and etiology. Similar to older children, see etiology of pediatric fever. However, severe infections are more common. A. ALS, scent invasive bacterial infections can occur secondary to 6LL7 copyright E. coli copyright S. galactii, Group B Streptococcus, OL monocytogenes OS aureus O enterococcus species. Viral infections that are typically mild can be life-threatening for young infants, e.g., 21. 7O neonatal HSV infection. O severe VZV infection. Fever in neonates can also result from dehydration. 8. Copyright infants. WA. And at shared note Ma. Clinical features. Febrile infants with serious infections may be well-appearing or only show non-specific symptoms, e.g., Froifi, O abnormal vital signs, copyright poor feeding, copyright irritability or excessive sleepiness. 1, 3 copyright abnormal appearance, O full fontanelle *. See also clinical features of pediatric fever. 3. Appearance is unreliable in neonates and infants. O and management approach. Scent. Obtain a full history, including birth history, examine the child, and obtain vital signs. Scent. Look for specific sources of infection, example cellulitis, if present, follow established treatment for that condition. 2. If there is no clear source of infection. Back collapse. Find text outline. If there is no clear source of infection, O assess whether the infant is ill-appearing or looks well. 1. Copyright. Determine exact age. Management of well-appearing infants depends on age. OSCE. Initial management of ill-appearing febrile infantates. Admit to hospital. Scent. Obtain full sepsis workup including CSF analysis. Plus start empiric parenteral antibiotic therapy. 5. OO degree and initial management of well-appearing febrile infant. Overview. 2. The advice below is based on AAP guidance and applies to well-appearing infants without a recognizable serious source of infection. CF2. Copyright significant past medical history. Copyright a history of immunization within the preceding 48 hours, if 8 days of age. 1. 2 *. Thoroughly evaluate all infants including those with non-specific symptoms and / or minor infections, to exclude bacteria co-infection. 1. 2 Diagnostic and treatment recommendations differ by age, i.e., 8 to 21 days, 22 to 28 days, and 29 to 60 days. Diagnostic studies for febrile infants. All infants. Plus inflammatory markers. Abnormal inflammatory markers in infants 0.5 ng/mLOCRP 20 mg/L. Copyright ANC 4000 to 5200 O. Temperature 38.5 degrees Celsius, 101.3 degrees Fahrenheit. Scent. Blood culture plus urinalysis with reflex urine culture. 4. Copyright inflammatory markers are not required in 8-21-day-old infants since empiric 4 antibiotics are always started in this age group. However, inflammatory markers can guide management. 2. Select infants, depending on age and clinical status. *CSF analysis. 2. Copyright. Provide supportive care for pediatric fever. Scent. Further management is based on age and laboratory studies. Overview of management of fever in infants. X. Fever in infants. Select infants, depending on age and clinical status. Plus CSF analysis. 2. Copyright. Initial disposition and treatment. Provide supportive care for pediatric fever. Further management is based on age and laboratory studies. Overview of management of fever in infants. Required if urine or CSF abnormal * required if CSF abnormal 29-60 days ARI. * consider for other patients. * consider for all other patients. WA. CE. Ongoing management. Tailor antimicrobial therapies if a pathogen is isolated. Infant improving. 2. Identified pathogen, continue treatment per guidance. All other patients. Copyright. Stop empiric antibiotics if blood and CSF cultures are negative at 24 to 36 hours. Copyright. Discharge home if equals clinical appearance is good. 1 equals HSV PCR studies, if scent, are negative. Infant not improving. 2. If the patient is not improving and / or worsening, scent. Start antibiotics, if not already started, or broaden antimicrobial coverage. * Consider non-bacterial infections, example HSV, fungal infections, and alternative causes of fever, see etiology. Copyright in febrile infants. Or prevention. Asterisk encourage pregnant patients to have recommended immunizations in pregnancy. Prevent vertical transmission of infections to newborns. O for early onset group B streptococcal infections, ensure appropriate, equals maternal GBS screening equals intrapartum prophylactic antibiotics for GBS1 equals monitoring of newborns at risk for GBS infection. Copyright congenital and neonatal HSV infections, see prevention of neonatal HSV infection. Scent prevent transmission to or from infants. Copyright practice rigorous hand hygiene and respiratory hygiene, especially around at-risk populations. Copyright follow guidance on when it is safe to return to daycare following an infection. Back collapse. Find text outline.